Summertime, and the leaving is easy. The fish are jumping, and the cotton is high. Oh, your mama's rich, and your dad is good looking. So hush, baby, don't you cry. One of these mornings, you got to rise up singing. Then you spread your wings and you take to the sky. But till that morning, there's nothing can harm you. With Dad and Mama standing by. But summertime, and the leaving is easy. But fish are jumping, and the cotton is high. Oh, yeah, that is rich, and the mall is good looking. So hush, little baby, don't you cry. So hush, little baby, don't you cry. Good morning, ladies and gentlemen. It's a big pleasure for me to be part of this Retinawesome and bring some musics from Brazil and from the world. I hope you enjoy. Dos gardenias para ti, con ella quiero decir, te quiero, te adoro, mi vida. Ponle toda tu atención, que será tu corazón el mío. Dos gardenias para ti, que tendrán todo el calor de un beso, de esos besos que te di y que jamás encontrarán en el calor de otro querer. Y en tus brazos vivirán y se hablarán cuando estás conmigo. Y hasta creerán que te dirán te quiero. Pero si un atardecer las gardenias de mi amor se mueren, es porque he adivinado que tu amor me ha traicionado, porque existe otro querer. Es porque he adivinado que tu amor me ha traicionado, porque existe otro querer. Dos gardenias para ti, con ella quiero decir te quiero, te adoro, mi vida. Ponle toda tu atención, que serán tu corazón el mío. Dos gardenias para ti, que tendrán todo el calor de un beso, de esos besos que te di y que jamás encontrarán en el calor de otro querer. Y en tus brazos vivirán y se hablarán cuando estás conmigo. Y hasta creerán que te dirán te quiero. Pero si un atardecer las gardenias de mi amor se mueren, es porque he adivinado que tu amor me ha traicionado, porque existe otro querer. Es porque he adivinado que tu amor me ha traicionado, porque existe otro querer. Un poquito de Latinoamérica también. E por falar em saudade, onde anda você? Onde andam seus olhos que a gente não vê? Onde anda esse corpo que me deixou morto de tanto prazer? E por falar em beleza, onde anda a canção que se ouvia nas noites dos bares de então, onde a gente ficava, onde a gente se amava em total solidão? Hoje eu saio na noite vazia, numa boemia sem razão de ser, na rotina dos bares que apesar dos pesares me trazem você. E por falar em paixão, em razão de viver, você bem que podia me aparecer nesses mesmos lugares, nas noites nos bares, onde anda você? E por falar em saudade, onde anda você? Onde andam seus olhos que a gente não vê? Onde anda esse corpo que me deixou morto de tanto prazer? E por falar em beleza, onde anda a canção que se ouvia nas noites dos bares de então? Onde a gente ficava, onde a gente se amava em total solidão. Hoje eu saio na noite vazia, numa boemia sem razão de ser. A rotina dos bares, que apesar dos pesares me trazem você. E por falar em paixão, em razão de viver, você bem que podia me aparecer nesses mesmos lugares, nas noites, nos bares, onde anda você? Nesses mesmos lugares, nas noites, nos bares, nesses mesmos lugares, nas noites, nos bares, onde anda você? Você. Imagine there's no heaven. It's easy if you try. And no hell below us, above us on the sky. Imagine all the people leaving for today. Imagine there's no countries. It isn't hard to do. Nothing to kill or die for, and no religions too. Imagine all the people living life in peace. You may say I'm a dreamer, but I'm not the only one. I hope someday you'll join us, and the world will be its own. Imagine no possessions. I wonder if you can. No need for greed or hunger. A brotherhood of the man. Imagine all the people sharing all the world. You may say I'm a dreamer, but I'm not the only one. I hope someday you'll join us, and the world will live as one. Okay, the traditional music from the Retinawesome. Yes. Penso che un sogno così non ritorni mai più. Mi dipingevo le mani, la faccia di blu. Poi d'improvviso venivo dal vento rapito e incominciavo a volare nel cielo infinito. Volare, oh, cantare, oh, nel blu, dipinto di blu, felice di stare lassù. Volare, oh, cantare, oh, nel blu, dipinto di blu, felice di stare lassù. E volavo, volavo felice più in alto del sole e ancora più su, mentre il mondo pian piano scompare negli occhi a tuoi blu. La tua voce è una musica dolce che suona per me. Volare, oh, cantare, oh, nel blu, dipinto di blu, felice di stare lassù. Ma tutti i suoni nell'alba svaniscono perché quando tramonta la luna li porta con sé. Ma io continuo a sognare negli occhi a tuoi belli, che sono blu come un cielo trapunto di stelle. Volare, oh, cantare, oh, nel blu, negli occhi a tuoi blu, felice di stare qua e giù. Nel blu, dipinto di blu, felice di stare lassù. E continuo a volare, felice più in alto del sole ancora più su, mentre il mondo scompare negli occhi a tuoi blu. La tua voce è una musica dolce che suona per me. Volare, oh, cantare, oh, nel blu, dipinto di blu, felice di stare lassù. Nel blu, dipinto di blu, felice di stare lassù.
Thank you very much, and we are pleased and happy to have you all here. And as we are next and close to the start, so I see here Athanasius, we have Jorge Mitri, Professor João Eugênio. How are you doing? Anthony Mack. I think Anthony Mack is Washington Slam's fellow or resident. So,
hello.
Everything all right? Are you in Thessaloniki?
Yes, I just had to come back to Thessaloniki because there is no internet in my area because of the wildfires that we had due to a very, very hot summer. The temperature went up to 47 degrees. And we had a lot of fire and everything and the electricity. So I decided to be on the safe side to come back to Thessaloniki and go swimming tomorrow in order to have a good internet.
Heat is hitting many countries, and in Europe and in U.S. and Canada up north as well. I have some friends there in Canada, and the whole city was destroyed by fire. This climate crisis is going on, and we have to try to reach the best deals in the political terms so that we preserve the world. It's not easy. It's a difficult task. And Dr. Lam,
you're cutting trees in Brazil, and we are burning forest in Greece. This is a disaster. Unfortunately, we didn't have any dead people this time, despite that we had 2 million acres that they were burned off. But we had burnt survivors, everybody survived, which is the first time in the history. So we're getting ready to have these things more often and more often, to be an everyday flooding and burning and doing. It's going to be a thing that we have to take care of in the future. And we're old, but our children are going to live with it. So unless we do something.
I understand. Dr. Lam, I'm happy that you came with 2 of your fellows and residents, and I was just wondering whether you could introduce them to us. What are their names?
Yes, maybe I'll help. Anthony Mack, he is actually a fellow, and he actually now is in the hospital, in the Queen Mary Hospital. He has to go in to see a retinal detachment emergency. So he's actually in the on-call room. And if there's any Wi-Fi issues, I will help to show the slides that he has. And the other doctor is Dr. Lee, and she is an associate consultant. Both of them are the members of the retina team in the Queen Mary Hospital, the Hong Kong West cluster. So I don't know whether Dr. Lee just signed on. So she is one of our retina staff who is quite dedicated to the work that she is doing. And she was involved in the cases that she's going to be presenting. So I'm looking forward to have her and Dr. Mack to join the group. This will be the first time, and I think it will be a very good learning experience for them to take notes from all the experts from the meeting. So thank you, Hassan, for the invitation.
I want to welcome
Natarajan. Hi, Watson.
Hi, Natarajan.
So I'm getting my thing ready to go to Greece, and I'm going to see you guys in what do you call in the through the internet. But I hope I'll get my visa. Hi, Thanasis.
Hi there. You will get a lot of suntan in Greece.
Yeah. Yes.
In India, Natarajan, things are cooling down.
It's cooling down, but still they have not opened up. I hope they are opening on Monday. But I don't know what's going to happen. When you open up, it's a problem again in India. So Monday they are opening up, and then what's going to happen, we have to see.
You're around? How?
Well, all well. Yes, everyone's very nice. Thank you very much.
1 hour, 45 minutes flight. No. Now Delhi has extremes of cold and extreme of summer. And in Mumbai, it's almost same, winter or summer. But we have heavy rains in monsoon from June, July, August. And one day a year, whole Mumbai is underwater. Like we'll be like Venice. Only thing we don't have boat. And dialysis has come in 95, I think, to my hospital. That time it was a very small hospital. And he carried my son like this with a hand. And now he's 6'1", my son, and he's 33, and I'm 18.
Son can carry us with one hand.
Yes.
It was a very nice hospital.
No, now my son came yesterday for dinner. He caught me like this and carried me like a baby.
But you are a baby, anyway. I remember how big was your hospital.
Yes.
When I was going in to see the hospital, you had to go out.
Yeah.
Both of us were not enough space for both of us.
Correct.
And remember the table on the roof.
Oh, correct.
Recording in progress.
Food otherwise. It was like the train. From the train, we borrowed that idea. A lot of innovative ideas, that son.
But
Jorge Mitri is there. Yeah. So we want to welcome everybody again for this 11th edition of Retinawesome. It's a pleasure to have started this with you, since the beginning of the pandemics. It's always a pleasure to learn. We are always learning every time. We have different and interesting cases. And because we are talking about learning, I have to introduce you a great professor of mine during my residency program here in Brazil, Dr. Professor João Eugênio. Professor João Eugênio, he's around already. Good morning, Dr. João Eugênio. Bom dia.
For all the purpose, the medicine doctor participate this.
I'm going to read a small biography from him, and I'm going to ask him 5 questions. These 5 questions are going to say, his whole life in the field of vitreoretinal surgery. This is very interesting. So Dr. João Eugênio is a former professor of ophthalmology from the Brazilian University and chief of the neuro-ophthalmology service from Sara Hospital Center of Sara Hospitals Network. He was graduated in medicine by the Universidade Federal de Paraíba, Brazil in 1960. He did his residency program in the Professor Hilton Rocha in Brazil at the University of Minas Gerais from 1961 towards 1963, and he was into the Brazilian Medical Association, the Brazilian Council of Ophthalmology since 1963. He did his specialization in Spain at the Barraquer Institute in 1970 towards 1972. And his doctor of ophthalmology by the Federal University of Goiás, our state over here in Brazil. Previous affiliations at the American Academy of Ophthalmology, Brazilian Council of Cataract and Intraocular Implants, and more. And that I cannot tell how extensive is his CV. So this is his small bio, very small bio. And I'm going to ask in Portuguese, and then I will translate into English. Professor João Eugênio, um prazer estar aqui com o senhor. Como que o senhor começou a sua prática em retina? How did you start your retina practice?
Depois de fazer o curso de especialização de 3 anos na Universidade de Minas Gerais, eu fui para o Instituto Barraquer, onde permaneci durante 3 anos, me especializando em retina com o professor Alfredo Moinhos. Depois, então, eu fui para o Retinal Service, em Boston, com o professor Schaefer, e no Moorfield, na Retina Service, trabalhando com o Schaefer, Mackenzie Freeman e Felipe Tolentino, que me introduziram e me especializaram mais na retina. Depois estive também em Houston com a professora Alice McPherson, no Neurosensory Hospital. Também no Hospital Kenzivan, em Paris, eu fiz um curso com o professor Pujol sobre ecografia na época. Na época, ele era a maior autoridade em ultrassonografia oftalmológica no mundo e tinha o melhor aparelho de ultrassonografia, era um aparelho francês que foi inspirado nos conceitos dele. Essa é a minha formação.
And including his campaigns, he's been to Barraquer. He mentioned some doctors over there and very eminent people. And his graduation and formation in the world of retina is very extensive. And I'm happy to ask him too that...
No, when did Hudson?
Yeah.
No. When did he start his retina surgery? Which year?
Yeah, for sure.
No.
And,
Which year he started retina surgery, Professor Eugideo? No. When did he start retina surgery?
did you spend some time, Natarajan?
No. Question is, when did he start the retina surgery in Brazil?
Yeah, that's true. Yeah, and interesting, João Eugênio, quais são como que o senhor compara? How do you compare vitreoretinal surgery at the beginning and today? Como que o senhor compara a cirurgia de retina antes e depois, antes e hoje?
Falar sobre a evolução da cirurgia de retina, eu tenho que reportar primeiramente o grande Gonan. Foi Gonan que apresentou na Société Française d'Ophtalmologie que o descolamento de retina não era o que eu pensava antigamente, que era uma retinite albuminúrica. Então, ele mostrou e apresentou casos operados de cirurgia de descolamento de retina, mostrando que a causa do descolamento de retina era produzido por ruptura. E apresentou, naquela época, casos curados com cauterização da esclera. Depois evoluiu com a ruga, apresentando a técnica de cerclagem, usando um fio sintético. Evoluiu depois para o Charles Schaefer apresentando a cirurgia usando diatermia e implante de silicone. O Custódio Linkoff apresentando as esponjas de silicone. E o Robert Marshall foi o idealizador da vitrectomia. A vitrectomia evoluiu, a princípio os aparelhos eram antigos, com as sondas eram muito grosseiras, com 2.000 rotações por segundo. Hoje em dia evoluiu para as técnicas modernas com 10.000 rotações por segundo e evoluiu de tal modo que hoje nós tratamos não somente descolamento de retina, mas através da via plana, a vitrectomia inspirada por Marhemer. Hoje nós fazemos tratamento não somente da cirurgia de retina, e com o advento da técnica de Chang, usando o perfluorocarbono, se faz não somente o tratamento de descolamento de retina, mas buracos maculares, membrana neovascular subretiniana, e hoje em dia, até fazendo transplante autólogo de retina para o buraco macular recidivante.
The surgery was amazing because when he started, everything started with, as he says, with Gonan. in Gonan, we have the Julius Gonan meeting, very important in the world today. But we started with Gonan, and then we passed to Mackimer and Skeppens and many heroes from today. And I still remember when I started vitrectomy, we had cuts less than 1,000, and Dr. João Eugênio mentioned 2,000, but now we have 10,000 cuts per minute. You know, the evolution from gauges. We started with 19, those times 20 gauges, and now we have 23, 25, 27, so things got a lot better in evolution. So Dr. João Eugênio lived all this history because he got to know these people, he was with them, and all this time he knows the evolution in vitreoretinal surgery. And last, he mentioned about macular hole surgery. I remember that back years ago, we spent so much time in one simple vitrectomy, and now with for macular hole surgery, we spent just maybe half an hour, 35 minutes, or maybe less. And so the evolution brings us to such a better environment in the field of retinal surgery. Another question, uma outra pergunta, Dr. João Eugênio, Professor João Eugênio, quais são os seus heróis na retina internacional? Você já mencionou, o senhor já mencionou alguns, né? Quais são os seus heróis na retina internacional? What are your heroes in the international retina field?
Alfredo Munhoz, de Barcelona. Professor Charles Escapes, de Boston. Mackenzie Freeman, de Boston. Felipe Tolentino, de Boston. E Alice McPherson, de Houston. Também me inspirei no professor Arquimedes Busaga, que é para mim o maior líder em biomicroscopia de retina.
Yeah, very good. Yeah, thanks for sharing that. And we all have our heroes. And you know, I have many heroes, but I have to mention that Dr. Lam, who is here, he's my hero because, you know, he virtually was teaching me almost everything I know in vitreoretinal surgery. And we are always learning, as I say, so we all have our heroes. And it's good that we follow their advices and follow on with the best practice as possible. Now, Dr. João Eugênio, quais são os conselhos que o senhor dá para as gerações que estão chegando para aprender retina? What are your advices for generations to come, the generations that are coming to learn vitreoretinal surgery?
Primeiramente, estudar bastante, ser um bom oftalmologista, especializado na oftalmologia, ter conhecimento da oftalmologia geral, e depois frequentar um bom serviço como fellow em retina, especializando em retina, e participar de todos os cursos de especialização em retina que ocorrem nos congressos.
He's saying, first of all, we got to study a lot. Otherwise, you won't reach anywhere. So, to have a general knowledge in general ophthalmology. I remember when I started my retina fellowship in Toronto, Dr. Lam always said, if you are ophthalmologist, you should know more than people that came before you in the first steps of specialty. So you should know a lot general medicine as well. And Dr. João Eugênio continues saying that you should apply for a very good retina fellowship so that you learn with good people, with good teaching, and to participate into many courses in vitreoretinal surgery, in retina, involving more staff and people that could teach you and make you very keen at working in these areas with very good knowledge as well. And the last question and the closing comments for Dr. Professor João Eugênio. Professor João Eugênio, nós queríamos pedir para o senhor os comentários finais, os conselhos finais, os comentários, quaisquer comentários que o senhor queira fazer para o pessoal.
É com grande alegria que participo dessa reunião com as mais autoridades e estou vendo aqui do lado meu amigo Jorge Mitre. Há muito tempo a gente não se encontra, mas eu tenho um prazer muito grande em tê-lo na minha lista de amigos. E muito prazer em participar de todos vocês como retinólogos e que é a minha grande inspiração e toda a dedicação de minha vida ao tratamento da patologia de retina.
Eugênio, eu quero aqui agradecer e dar minhas honras a você, que você sempre foi um grande oftalmologista, aprendi muito com você durante a minha vida e só tenho a agradecer ser teu amigo. Muito obrigado.
We are so pleased to listen to Dr. João Eugênio and Dr. Jorge Mitri's comments. And Dr. João Eugênio said he's very happy to be around us here into this meeting and to participate. And the retina is the inspiration for his life, and he loves the pathology of retina. Thank you very much, Professor João Eugênio, and thank you for being with us. You know, it's an honor. We are honored to have you, and I'm very pleased to have you as my retina professor during my residency program here in Brazil. Thank you very much. You and Hilton Medeiros, your son, is a retinal specialist as well. He's a very friend of mine, so we are so happy to have you all here. And now I want to introduce you to our keynote speaker, Athanasios Nikolakopoulos from Greece. And Athanasios is very important.
Eu queria fazer só uma pequena lição. Deixar aqui um forte abraço ao André Jucá, a quem eu devo muita atenção. Eu estava participando de um congresso de Fortaleza, quando fui acometido de um infarto de miocárdio, e ele foi de uma dedicação extrema, me visitando diariamente durante minha hospitalização. Um grande abraço para o André Jucá, a quem eu considero um amigo e tenho uma profunda gratidão.
Daniel wants to point out that André Jucá, who is participating since many Retinawesome programs here, he helped him a lot because he had this heart stroke, and André Jucá was with him all the time and helped him a lot. André Jucá, our friend from Retinawesome. Thank you, André Jucá, and welcome back again to Retinawesome 11.
Thank you. It's very nice being here. Thank you. Thank you, Dr. João Eugênio. Was nice helping you. Was a great moment, but you are a very strong man. You are much better after the stroke. Very nice.
Thank you, Dr. João Eugênio. And our friend and Athanasios, how are you?
Well, it's a great honor to be among these great people. And I would like to congratulate you for remembering the people that they taught us so many things that we know, because we were just sitting on the shoulder of these men that you introduced us before. In order to be able to talk about new things, we have to step on the shoulder of the previous speaker.
And we are pleased to have you as the keynote speaker because, you know, we learn a lot, as I say, and you have actually a school in summer school of Thessaloniki. This is very interesting. And so would you like to share your slides, or do you want me to share, and so that you could start your presentations?
Because I had a few cases, surgical cases, would you like to show you first the school that we're doing all together, or would you like to show you the cases first and then the school? I mean, this is your choice.
I would like you to show the school first, because we want to know how people are getting engaged to the school and how can they work, you know, and learn into these pandemics. And your structure is very good. So you could probably start with your schooling and Thessaloniki school, summer school.
It's just slides. So if you have my slides, you can project them and I comment on them. If you want me to show my slides, it's all the same to me. But if you have the slides and you want to project them, I can follow up the slides.
Start with your presentation here, and let me just share my screen. And
Hudson to share. I just want to tell the secret that Thanasis, Dr. Cesare Forlini, and Eckhart and all were learning from Dr. Jovanovich from Rotterdam days, and it was great to see Dr. Thanasis here. And now he's celebrating his 10th year, and I'm glad I'll be with him.
Okay, I just want to tell you that we thought that there is a lot of new things coming to the vitreoretinal surgery every year. And the accessibility of these new things like 3D, like indirect ophthalmoscopy, microscopes, new microscope, OCT surgical, are not accessible to all the people that they are involved in retina surgery or in cataract surgery. So we thought 10 years ago, if we get all the friends together in a nice, friendly Greek atmosphere with a lot of tavernas around us, if we can make a sort of a knowledge transfer of new things to people that they don't have access easily to them. So if you, we decided to do something in Thessaloniki for 1 week to get all our friends together, like I hope you're going to be one of them in the future, and to make a sort of a school that we call it informal school with a lot of very, very high quality surgeons. And can you get to the next slide, please? Or I don't know if I have access. And the one guy that we were together with Nataraja, and that was Cesare Forlini, who died recently. And he was the one who had the idea to form the Vitreoretinal Society, which is an informal Vitreoretinal club, who's organizing meetings like that. And it's live meetings, and missing Cesare Forlini is like missing myself also. It's a big loss. And thank God we have Matteo Forlini, his son, to follow his steps. Next one. People don't know where Greece is sometimes. They come from all over the world, South America, South Africa. And Greece is a place where it's a small, tiny country of 10 million. And somewhere here is Thessaloniki, which nobody knows. And this is the whole of Greece. And the nice thing that people know is these hundreds of islands in the middle of the Aegean Sea. Can I have the next one? This is Thessaloniki, which is a very 1 million people city at the northern part of Greece, near the borders with Serbia and Macedonia. And this is it's a sea city next to the sea with a very old history of 2,500 years. And people don't know a lot of it, so we decided to make it accessible to people, because it's very difficult to find out. It's very easy to go to Athens or to the islands to make a meeting. It's impossible to come to Thessaloniki to have one. Next, please. This knowledge transfer is the word that we are training, update the latest advances of VR pathology and true to live wet lab training by expert. This true to live wet lab is something that we will discuss later. Can we go to the next slide, please? I was taught by Makemer, which I was happy to be with him in a couple of meetings, that progress comes from doing the unconventional. And next slide, please. So unconventional is to get together to bring a lot of equipment, a lot of people teaching, a lot of people staying all together, and spending a lot of money, being a very highly cost wet lab session for a very few people, because we cannot accept more than 20, 25 people at a time. Otherwise, you cannot train them well. And there's a theory session in the morning, And then this is the difficult part. We're using the latest machines, microscope, an on-contact viewing system, an Ingenuity system, 3D training system, and only basically using the artificial bionic eyes, which is incredible in macular surgery because they can be reused. So it's like having 12 to 15 surgical theaters in a big auditorium. Imagine that these theaters are not even, they are much better than my theater. They have everything included there. So you're not getting to the tabletop microscope with a little big eyes that you cannot see what's going on. You are in 12 surgical positions with the latest and more expensive technology. And thanks to the industry, we can provide that. Next. Another big opening for transferring knowledge, it's the 3D session, the digital viewing systems, that they allow people to see what exactly the surgeon is doing. So if somebody is doing some surgery in front of the other people in an artificial eye, everybody else can see exactly what he's doing. In the old days, the only one who can see exactly what the surgeon is doing with the same viewing system, it's only the assistant. So imagine that you can have 500 people in an auditorium and see exactly what you're doing. Next one, please. Digital evolution is coming very quickly, and we have to transfer this knowledge to people because it's not accessible to everybody. In the future, there is a lot of things like helmets that you can use the digital evolution to do, and because you have a very high magnification, a very detailed situation, and a lot of technical details that people who are experts like Riemann, that is coming to the TVRS, they can transfer this knowledge and tell you what are the basis of this transfer. Next one. This is a setup of a TVRS through to live surgery. You can see you have Hackstride 900 microscopes. You can have the latest screening and viewing system by Biome and ABUS. And next one. Because it's a completely different story to do a surgery in an artificial eye, seeing through Ingenuity or through digital systems, and then having a foot pedal and controlling yourself to what you're doing. And it's a complete different thing to have a big eye, a tabletop microscope who doesn't have foot pedal, because it doesn't give you the same feeling, the same touch, like the true to life setup of a real surgical system that is going to hold on. And until last year, we also had a surgical OCT to train with artificial eyes, which is very few people can have it in their own theater. Next. So this is what I'm telling you. The biggest opening that we have, the best thing is this Bionico eyes, and I suggest that to try to open the website and see Bionico with a K. These people from Miami are making artificial eyes that actually can imitate everything, and also they are reusable. They are not, you use them once and then you, so it's cheap system that you can put in your microscope and you can start training in any new system you've got. If you got an Ingenuity system, don't start immediately with a human eye. Start immediately with an artificial eye. And if you have this artificial eye in your theater, it's very good to train yourself and your fellows in all the new techniques. Here you can see we have a surgical OCT, we have 25 gauge, a constellation system, a biome system on top, and then we have this, and all is set in a wet lab. Next. This is one of the setups we have. I don't have it in my theater and I have it in my wet lab because the industry is understood what we're doing and they're helping us without us to have to pay for that. And they bring us the instruments, they bring us the microscopes, they bring us all the latest technology. And so we can have this accessibility. Otherwise, we wouldn't be able even to transfer them to Greece. Imagine that these big blocks that come from Haxrite, Germany, 3 microscopes every time, they come by plane. The cost of it to come to a wet lab. Next one, please. And this is the system I'm using, the ABLE system, with a fingertip that I can focus without using another foot pedal, which is 100 foot pedals in my foot. Next. This is the training setup in the auditorium, and in the we transfer some live surgery from my surgery to the auditorium every time we had to do, and then they practice in artificial eyes or pig eyes. And also we got special guest people like Ernesto Bali, or that they do live surgery from Belgium or from Italy. And we see that. Next one. You can see what is the difference. The difference is that you have a very high magnification without losing any detail. So the resolution is incredible. You can see the vessels, you can see the blood flowing in the vessel. You can never have a resolution like that in a microscope doing a wide angle observation system. You need to have this kind of digital technology in order to make detailed things in the eye. And macular surgery has become a toy using these systems. And we have to transfer this knowledge to all the new people that they don't have accessibility to these areas. Next one. Another issue is when you start alone, when you start by using a guidebook or just a new machine. We have a saying, say, before you start anything, learn how to finish it. Because starting it is easy. You can put your instruments inside and start it. But to finish it well, it's another story. And everybody who's doing retinas, you can understand what I mean. Next one. The learning curvature, next one, that we teach. And this is a motto that we have. We just use scissors to make I can't do it in I can do it. And TVRSGR is a website that we have to show you how you can enter the things, how you can see things. And we hope that Retinawesome and Fusion would be part of TVRS, as we are going to be part of Retinawesome, because transferring knowledge is an international thing and is not something that has to do with borders. Next one. Another big issue about TVRS, that we have a whole day that we're teaching cataract surgeons how to treat cataract complication treatment the way you did the seminar in the old days. I don't know which Retinawesome was that, but we had a lot of interesting ideas of how to fix things when they go wrong. And if you have these systems, you can transfer this knowledge to cataract surgeons. So the whole day, it's this. Next one. This is about the bionic eyes that you have to have. Next one. This is how they learn to do a handshake in an artificial eye, how to remove a foreign body. So there's a day with trauma surgery dedicated to Cesare Forlini, and we call it Trauma Day, Surgery Forlini, Trauma Day, which Faisal Fayyad this year is going to show an exhibition of trauma cases, how to treat them, because trauma is not taught in anyone. They just tell you when you get in a hospital, we had a trauma case, come and fix it. But nobody gives you a thorough trauma fellowship, and nobody's doing it. That's why Forlini Trauma School is very important to be included in the wet lab seminars. Next. Another setup. Next. This is the general view of how we sit. In the morning, there are lectures how to do, for example, how to suture an iris that has been cut off. And immediately the people on the wet lab seats, they have to do the suturing. So it's a lecture transferring knowledge and doing the same thing. And this is going on for 5 days. And it's 8 o'clock in the morning, on 3 o'clock at noon. We have lunch together. Then we have a session of wet labs until 8 o'clock in the evening. And then we have a dinner together. So the teachers and the people are together. Next. This is an older setup because we evolved. We had 10 years of doing that. Next. This is a 3 years before setup, which is similar because you can see multiple kind of machines here, not one kind of machine. We have Dork machine, we have Constellation machine, we used to have Synergetic machine. We don't have Baal Shalom because they don't like us, but we have everything else. Next one. This is the setup for the Ingenuity. Next one. This is last 2 years, because we lost 1 year due to the pandemic. Next one. This is the famous Florian Balta from Romania. And this is me trying to see what's going on. And next to me, it's my son, Konstantinos Nikolakopoulos, who is a retina surgeon in Lausanne now. And I'm happy to see things happening generation after generation. After all, I'm a third generation ophthalmologist. He's a fourth one. Next one. Yes, everybody has to wear 3D glasses in order to make an Ingenuity exhibition. Otherwise, this is 3D surgery. And another thing is, we call it, students are voting for the best teacher. And because we had a dinner at the end called Barbuni dinner, that's Trilia dinner. It's a red fish, red mullet fish that we had as a celebration in the last day. So we give a golden Barbuni award to the teaching award that is very rare and only a few people have it. Bandello has it in front of his desk and everybody asks him, what is that? He say, you cannot have that. Next one. And this is where Barbuni dinner is given in a seaside in Thessaloniki, and it's worth coming even for the social events that we have all together. And this is a campus-like thing where faculty is integrated with the students. Next. Listen, what is the secret of TVRS? The international guest faculty for 2021 is Avitabile, Balta, Blagoeva, Carlevale, the same, is doing Carlevale lenses, the same Carlevale. Fayad from Jordan, Franklin from USA, Forlini from Italy, Atanasova from Russia, Ferrara, Nataraja, Tommy, Drizin, Ripandelli, Kaskaloglu from Turkey. Next. And this is how the international, you see Purnaras here teaching, you can see how international guests are teaching. It's like man-to-man teaching. Next. And 14 faculty expert. Next. Greek faculty. And you see how the Greek faculty is teaching. You saw how the international faculty is teaching, and you see now how the Greek faculty is teaching. We have a different way of approaching things. And imagine, next one. And 5 virtual presentations from Retinawesome, from Wai-Chi Lam in Hong Kong, which is one of the best teachers we ever had, and one of the big fans I am from Wai-Chi Lam. We hope to have Hudson doing a virtual presentation, and Bandello and Kaynak from Turkey. Next one. And that's the secret. 50 human power for 21 participants. Have you seen that before? 15 international experts, 14 Greek experts, 5 virtual presentations, 4 wet lab people doing from Poland, they come all the way from, 2 bionians, they come from Miami, the guy who's doing bionic eyes. And imagine that there are 50 people to train 21 participants. Whatever, it's completely unacceptable from the value of money value. We always are on the red. But this is the secret of surviving TVRS. Next. And that's the last slide. And we start early. TVRS is open to youth. And these are my two youngest children that I got a few years ago. So we would love to have you. Next one, please, if you have another slide. But the last one that I suppose that we have it is in August 3rd to September 3rd. Unfortunately for 2021 is fully booked because we have a very limited seating. Otherwise, it's not going to be such a quality and such value if you have less teachers. But show me another wet lab with 50 people involved for 21 students. Thank you.
Wonderful.
Slides, and it's so good to see how structured is that school, you know, people attending. I'm very happy to see that, and thanks again for the invitation. Of course, many more people deserve that, and I will extend this invitation to Professor João Eugênio as well, and many other people. And Athanasios, do you want me to share one of your recommended surgeries?
Okay, you choose.
Okay.
No, by the
Yes.
time you shared, I wanted to say that when we all used to go to Jovanovic, it was a tough time to see what was he doing. And he was full of his ideas, and I'm happy Thanasis went through that. And I remember watching Dr. Skipens, and then with Cesare Forlini, I think whatever he had difficulty or we had difficulty to learn from the masters like Dr. McNamara, Skipens, and Jovanovic. And I think Eckhart also was along with us. I'm glad he is now giving it like a ready-made recipe to the young ophthalmologists. And I wish all over we have to create like that. But Thanasis is a pioneer. And I think he's also a teaching faculty in Lugano. And as he said, even Lugano has to learn from Thanasis. And I think Thanasis, hats off to you.
Thank you, my friend. And you know that Lugano and Guarnacha was their idea was for the Greek TVRS, because Guarnacha told me that in Lugano everything is very expensive due these years, and in Greece everything is very cheap. So say, why don't we get the cheap prices of hotels and everything in Greece in order to make such a thing? So Esaso is our mother company, and Guarnacha is going to be honored. The Esaso inventor is going to be honored this year, and I hope you'll be with us to share the prize.
And I hope like how you are having mother as the Lugano, and I hope Mumbai will be another small student of Thessaloniki.
Let me just take a little bit of your time to tell you one thing. All the people in Europe that are fine surgeons now, like Matteo Forlini, like the youngest one, have been through India. Don't forget that. And you have to do some mentioning on that, because you're training highly skilled surgeons, and you don't say that to anybody. But I know how many of these people have been trained by Indian surgeons. You got quality, you got numbers, you got abilities. So thank you for training people in real life surgery. We're doing wet labs, you're doing real life surgery.
Yes.
For your comments, and it's always pleasing to see your smile. You know, you are always happy, and we are pleased as well. That contaminates the environment. That is really good. And
that's the difference between me and Thanasis. No, every day we spend every evening after the teaching all over the world somewhere until midnight or early morning.
You are eating and drinking. Don't start talking. There are other people in the auditorium also. Don't start talking.
I want to add the summer school is amazing. So I hope, Nicholas, that you will accept trainees from Hong Kong, and also for them to have that opportunity to have that such a wonderful learning experience. That high ratios of trainer versus trainee is unheard of in any program. So I'm very honored to be taking part at the different programs in the past. And I really look forward to have that opportunity extended to our trainees. Thank you.
Just an open invitation that I would like from you. My son asked me if you can train him yourself, because he saw Mavrikakis and he's an excellent surgeon. Say, if you have Wai-Chin Lam, a friend of yours, can he do me a favor and teach me? He's not coming to me at all. He wants to come to you. He never seen me doing surgery.
It will be my pleasure. It will be my pleasure. Yeah, it will be my pleasure.
You don't know that.
Yeah, no, it will be my pleasure. But I want to pitch it from our trainee to be in your summer school. And also to India, to Natarajan, to get those hands-on experience, and it will be wonderful for them to have,
Sure.
because you exactly what Nicholas said, that you have such a opportunity, such a large patient population and such skill that they will benefit for those opportunities.
Yes, I love teaching, and I have, as Thanasis said, so many, even John used to send a lot of people, and I think many Europeans have come, not only European, many other countries, all are welcome. And we will have happy to have you as a faculty too, Vaichi. And Thanasis has come several times as a faculty. Only Macamar I could not get, and our friend Zelia also have to come one day. And I'm inviting for more than 15 years. And
Thank you.
Everybody has come.
Can I share your video now?
Yes, yes. This is a surprise. They asked us to remove a dropped intraocular lens together with a capsule that has fallen into the eye. And we are using the 3D system for this, but we have a 2D presentation in order to have. And you see the bimanual technique is very, very good. And handshake technique is what we teach some many times. And it means that with one hand, you can hold it, and with the other hand, you can do things to the capsule that it's invented inside the lens. So in order to remove it, we have to remove first the capsule and then the lens. Sorry for the... And then we show something like that. You know, what is this that is coming out? I have a block in my screen. I don't know why. You have a block here. There it is. Sorry, can you remove this black thing from the screen? I don't know why is that, Hudson. There's something blocking the screen. Yes, it is still blocking.
It's still blocking us.
No, it's still there.
Upper right.
Sorry, we lost. This is how we get in. The surprise was that he had two posterior capsule rings inside the eye together with the lens. Well,
Yes.
if you can, yes. You see, this was an unstable lens, and he put the previous surgeon has put a fixation ring, and the fixation ring went down, and then he put another fixation ring, and it doesn't matter how many fixation rings he has put, the whole thing went down. So we removed the lens, and then suddenly we saw one fixation ring, and then while we're doing the canalog cleaning, we got another. You see, we got another ring coming out. So when you finish, I'm going to show you, they were intact. But I just want to tell you something at the end when the video is off. Now we do the cleaning with the canalog. We remove completely the... Look what kind of lens. Can you stop there? Can you stop it there? Look, this lens it's inappropriate to put it in the sulcus or supported by rings. So it has no chance to survive. But I'm going to show you that we have taken 2 or 3 lenses once. Somebody has put one lens, dropped down, put another lens, dropped down. And this is how people try to survive the cataract surgery. And this is what we do in the school. We just teach people how to treat them when they have a cataract complication. They shouldn't have a lens like that. They shouldn't have 2. And at the end, we can sell those 2 intact scleral rings and the lens. Thank you.
Dr. Lam, would you like to comment on the Athanasius case?
Thank you. That is an amazing case to share, to have 2 capsular retention rings. It's always a surprise to not fully anticipate what's going to happen. You show a very nice way to remove it. Sometimes I find the capsular retention ring can be quite problematic to remove because of the large size or circumference of it. And I have found if you use the inserter to hook it and then retract it, you can remove it with less issues that it might harm or you might traumatize the surrounding tissues. I found that that's one way of doing it. But in your case, they seems to have come out very easily, so that doesn't seem to be much a problem. But those capsule retention ring can be problematic to remove.
Well, I fully agree with you. This is the best way to do it. But I did the first one easy, but I got surprised when I saw the last one because easily I would be lefting the last one in. If I didn't check with Kenalog at the end and everything in the area, I would, because it's not visible.
Yes.
In the side of the eye. So you have to look for a couple of things in the eye before you finish it. That's what I say. Before you finish, you have to know how you finish the case. And for me, every time I had to remove the whole vitreous and I had to use Kenalog to see, because I don't trust my eyes anymore. I've seen so many times that I have left things because I didn't use Kenalog. And it has to do with membranes, it has to do with eye length, with everything. So I'm using all the time Kenalog for this.
Yeah, absolutely. You can never be too careful. And I think reviewing the previous operating note can help, or talking to the surgeons before the surgery can help you to have some plan when you do the surgery to try to minimize the surprises. It never is good to get surprises.
Hudson, can I show a 1-minute video of a blunt retinal detachment, which is has a lot of surprises inside? Yes, but only the video, not the whole presentation. It'll be a short one. It's a 2-minute video. The thing that I'm going to show you is a young guy who had a motorcycle accident, and he was incubated for several months, being almost in a coma. And then you can see that he found out when he wake up after 6 months that he had a retinal detachment in one eye and a very, very low vision. And the curious thing about it, that he has a blunt trauma, but he has subretinal strands. And also he had a couple of round holes that you can see them now with a cryo probe when I try to detect. When I try to detect the hole, I'm using the cryo as a detector. And you can see here that you can cryo the area that I have doubts if it's a hole or not. And you can see that the whole area is frozen except the hole. And there are many holes. It's a flat retina and has a lot of subretinal strands. I was taught by my masters that if you have subretinal strands, you have to put a buckle in order to release a little bit of their tension before you do anything. But see another curious thing. I put a 3mm sponge but I'm using not the indirect ophthalmoscope, I'm using the light pipe, which is the modern way of doing buccal surgery and doing vitrectomy in the same time. So then I follow the vitrectomy, but it looks like a very flat retina. And I say, after 6 months with subretinal strands, how is it possible for the retina not to have a PVR and have subretinal strands like that? You can see how deep they are. So I tried to remove the vitreous and I saw something incredible. After 6 months retinal detachment, the vitreous was attached. And as soon as we remove this attached vitreous, which is like a membrane anymore, it's not vitreous, then the retina became mobile again. So never taking for granted that after a few times, now we have to do an air exchange and we have to cut a little bit, doing a retinotomy, and I'm using 27 gauge in order to remove subretinal strands because it was unable. You can see I removed subretinal strands at the end because we were unable to flatten completely the retina with gas. And we do all the surgery under air in order to keep the retina back, because under perfluorocarbon, when you have such stress, you might go behind the retina. So we try to do it under air, which is much easier and much, so as you see the subretinal strands moving, you see the retina is flat. But the take-home message is not taken for granted. And if you see a case that is young and flat, despite 1 or 2, 3 years, that means that the vitreous is still holding the retina back. That's why the retina was immobile and flat. That is the take-home message, the surprise that we had. Thank you very much. I think we have to stop here because I monopolized a lot of your time.
Here, my good friend Euler Vencio from our city here. I remember back many years ago when I was doing my retinal fellowship in Toronto, he visited me for 1 month and he spent some time with me, Dr. Lam, Dr. Berger, Dr. Divani, Dr. Harvard. That was a great moment, and he's watching us here, and of course he's invited for next Retinawesome editions. And I also want to welcome Yoshihiro Yonekawa from Will's Eye that just came in. And now I want to call Dr. Lam with his residents and fellows to present such nice cases. And actually, Dr. Q is going to start the case and Dr. Lam will follow on. This is really interesting. Just wait and see.
Thank you. I want to introduce Dr. Lee. I did that introduction a little earlier, but I think a lot of the participants has not signed in yet. So Dr. Lee actually is the associate consultant of the retina team at the Grantham Hospital or Queen Mary Hospital. And she is one of the junior staff in our team. And she is the most dedicated person I've ever met. And she will spend hours looking after patients without any hesitations. And so today she's going to share with you an interesting case that we actually recently managed in the last month. And so I'll let Dr. Lee to start off.
Yes, good evening, professors. I will share a case with an 8-year-old girl with morning glory anomaly. And she presented to us back to September 2019 with the inferior retinal detachment. The visual acuity was hand motion, and the retinal detachment progressed to total retinal detachment and temporal retinal scaffold in May this year, and the vision was dropped to light perception. So in this RedCam photo, we can see there's a morning glory anomaly with the inferior columboma. there is a total retinal detachment and temporal retina star fold. Here is the surgical video. We do the triamcinolone assisted posterior vitreous detachment. The posterior detachment was very difficult, which is very adherent. And you also remove the glial tissue by the serrated forceps. There's a mild bleeding over the disc after the glial tissue was removed. And then we remove the peripheral hyaloid. And vitreous is so adherent that we can only detach the hyaloid up to the equator and remove the pre-retinal fibrosis over the star fold. We can see the blood clot over the disc is accumulating. And then we remove the blood clot over the disc. We tried again and again, but it's very difficult to remove all of them. And then we do the retinectomy and fluid air exchange to remove the subretinal fluid.
We couldn't find any peripheral retinal break with the scleral depressions. That's the reason why we decided to do a posterior retinotomy.
And after the drainage of the subretinal fluid, we laser on the columboma edge and also laser all the disc.
So we do a circumferential laser. So we were quite pleased at the end of the surgery. And go on.
But at the postoperative day 1, we found there's a subretinal gas bubble beside the disc. And in the postoperative day 7, the subretinal gas bubble enlarged and the retina touched the lens. This is the RECAM photo showing there's a large subretinal gas bubble and pushing the retina approaching the lens capsule. So there's the question, how to drain the subretinal gas in the second operation? Why the gas bubble goes subretinal space, and how to prevent the gas bubble going to subretinal space again. So here are some slides to introduce a little about morning glory disc anomaly, which was results of the normal closure of the fetal fissure. And the disc anomalies finding include the optic disc excavation, and which is a symmetrical defect. And there is a central glial tissue, and with severe papillary pigmentary disturbance and anomalous retinal vasculature. It usually more common in the female and rare in blacks, rare in familial or bilateral, and is rarely associated with multiple system genetic disorders, except several still. Here is the end of my presentation.
So the question posed to the group is, how did the gas get subretinal? And also now that we have a total retinal detachment related to the subretinal gas bubble, what will be the people's approach to this case?
Hi, Dr. Lam. Hi, Dr. Lee.
Yeah, I'm thinking of you exactly.
Hi, good morning.
Yes, good morning. Because you are probably one of the few who will enjoy doing pediatric surgical cases.
I'm not sure if I would enjoy this particular case because morning glory disc anomaly related retinal detachments, it's one of the most challenging cases that we do as retina surgeons. But I loved your approach to the case where you stained the vitreous multiple times to make sure you got the hyaloid up and very diligently performing the vitrectomy. And I think when we think about morning glory retinal detachments, This case was clearly like a rhegmatogenous issue because it quickly progressed. You had star folds. You had that star folds means PVR, meaning there's a break somewhere. But morning glory can also have serous retinal detachments, which can be sometimes quite severe, but they don't progress as quickly. And so I think making that distinction is really important. And so for milder serous detachments, you can observe. Sometimes I've used a Diamox with mixed results. I think that's one good option too. But if you have to go into the eye, usually, I try avoiding it if possible. And I hope that there's a peripheral break so that you can just use the scleral buckle. But I think a lot of times, like in your case, you don't identify a break, and it must be something kind of around the disc, like a micro break somewhere. And I think that's where the gas went in also. I usually use silicone oil with these cases, but I've had issues with optic disc anomaly surgeries where I find that the silicone oil even goes underneath the retina sometimes. And I think it's through the anomalous disc. How to avoid it? I think it was a great idea to laser the coloboma. I don't usually do it, but I wonder if it's good to laser 360 around the disc also. And regarding the gas bubble management here, I think if it's a localized gas bubble, it's okay to just watch. I'm sure it's superior. If it's not keeping a break open, I think you can leave it alone. But if it's causing a total retinal detachment like it is, there's something more going on here that the gas bubble is doing and probably needs to be removed. I hate to go back into these eyes, but I think you just have to make another either a retinotomy, or you can drain externally too.
Those are wonderful tips and very great insight into managing this case. And I'm going to show you what happened, and that actually will then quickly answer some of the questions. Dr. Lee, can you stop sharing, and then I can share my screen?
How to stop sharing?
Just to, I think you have an option in your screen share to say stop share. Right, okay, perfect. And yeah, then I will go on to mine. Yeah, she did. She did that already. So yeah. Okay, so so what happened is that, so I take her back to surgery just actually this Thursday. So it just happened at this quite very moment. So to start off, I actually drained the subretinal, because there was a large subretinal gas bubble. And in fact, the retina at this time is already totally detached with a large gas bubble. And the retina is elevated right behind the lens. So I use a trocar to enter at 12 o'clock about 2.5 millimeter from the limbus to enter into the gas bubble. And you see, once I entered, the gas bubble get escaped. Sorry, that didn't show quite the gas bubble escaping. So I did a lensectomy. And then you can see now the total retinal detachment. And I found there was some residual vitreous. So I went on to remove whatever residual vitreous that's there. I still couldn't find any break. But because there are some posterior break that during the removal of the vitreous, what I was able to identify. And I will stop here. So I laser them. And when I was lasering those holes, then I looked back to the posterior pole. You can see now there is a subretinal gas bubble migrated into the nasal aspect of the disc. And you can see now a blister of retinal elevation with subretinal gas. So there is a communication, as Dr. Yushiharu mentioned, that there is a small break. Whether it is a small break or there is a communications from the optic nerve coloboma that created the opportunity for the gas bubble to get subretinal space. So I look at it and say, what I'm going to do with this, and I tried to kind of push it a little bit with the soft tip cannula. I still couldn't do much to get rid of this subretinal gas bubble. And so I went on to do some peripheral laser, and the gas bubble instead get progressively larger. So Dr. Lee suggested that perhaps we can consider using tissue glue over the optic disc, over the coloboma, and that could have sealed the migrations of the gas into the subretinal space. And so that's what we've done. And but then we realized that there's still some gas bubble coming through. And actually what had happened is that the two solutions that mixed for the TCL didn't quite mix properly. So I think I only managed to get some plasmin in it, but didn't get that plasmin fibrin mixed to create that fibrin clot. So I quickly realized that I then put in the fibrin tissue glue right over the disc. Then I make a small retinotomy over the gas bubble and then drain that, and then did more laser around the optic disc and completed the surgery. So, I suspect in this case, the communication between the optic disc and the subretinal place is through the optic nerve coloboma, the morning glory. And I cannot find any actual bricks. And if you recall, at the beginning of the surgery, in the very first surgery, there was actually no bricks around the coloboma at all. I did a 360 laser during the first surgery around the optic disc to try to limit the chance of any communication or leakage of the subretinal fluid through the optic nerve coloboma. So I'll stop sharing and like to hear other comments.
Some years ago with a woman with coloboma, and I started with scleral buckling surgery. It went very well, and then after a while she had the retina detached, and I had to go for vitrectomy. But since I did not have the TZU and I did not use this glue part, I was afraid of only using gas, and maybe because she's got some PVR at the beginning, and then she ended up with silicone oil, and then after some months I removed the silicone oil, and she's very good now. She's reaching 20/50, but she had this coloboma and the same mechanism, you know, and it's great. In what time you put the glue to actually hold the retina in place during your surgery?
It was after the complete air-fluid exchange. I have to say, this is probably the first time I actually see subretinal gas bubble migrating into the subretinal space, a gas bubble migrating to the subretinal space through the coloboma. And it really kind of impressed me about the mechanisms that people have proposed, the communications. And I actually quite glad that I didn't use silicone oil, because you can imagine the oil will be behaving just like the subretinal fluid migrating into that subretinal space and creating a persistent detachment that will be even more challenging to manage compared to a gas bubble. And I have to say, this video was kind of amazing to me, because for personally seeing what's happening, and I think Dr. Lee was flabbergasted and seeing that, oh, you know, the gas is moving in, also actually air is moving into the subretinal space.
I think this is very unusual, especially because gas has very strong surface tension, so it shouldn't sneak into these areas unless there's some kind of abnormality in terms of like the eye pressure or the maybe like the direction of the infusion perhaps may have been directed towards the nerve. But the other thing that kind of leaks into the eye in these cases, it's subretinal fluid that reaccumulates, causing like an exudative detachment after surgery, which is another thing that we worry about. And there the mechanism seems to be the communication with the central the CSF. Yeah. And then but this is really concerning, and I agree that dealing with subretinal gas so much better than dealing with subretinal oil, where you would have to make a huge retinotomy, and that would just recipe for disaster. But a beautiful case, and I think we learned a lot. And I would love to see this case published, and you talk about it in your discussion.
Yeah, I agree with you. I think it probably because of the air infusion pressure, although it's not unusually high. We usually set at about 25 to 30 millimeter mercury, as we normally do. But the fact that you are pressuring the eye with this air infusions, whether it's directed or not to the optic disc, may be the driving force for it. But it really consolidates the idea that there is communication between the coloboma disc to the subretinal space, and that gas, that subretinal air bubble actually progressively gets more involved and during the procedure. And I think I'm hoping the tissue glue will cover the defect, allowing time for the peripapillary laser to form firm enough adhesions to prevent further communications. And I'm planning to add more laser in a postoperative period time before the gas bubble or before the fibrin clot completely dissolved. Usually takes about a month for the fibrin clot to start to break down and digest away. And I'm hoping I will able to do some laser around the disc to limit or enhance the adhesions to limit any further communications.
Yeah, beautiful case and so creative. Thank you.
Thank you.
Salem, and I would like to follow with Dr. Zélia Correia. She's at Bascom Palmer Eye Institute. She used to be in Cincinnati, and she's got an extensive knowledge in vitreoretinal surgery, and especially on ocular tumors. It's a great pleasure to have you again, Zélia. You were keynote speaker for Retinawesome 10. That was amazing, your cases, and we have to get them recorded. And welcome you. I welcome you back to Retinawesome 11 now. Thank you very much.
Thank you, Hudson. It's a pleasure to be here. It's a pleasure to be with all of, esteemed colleagues, very experienced vitreoretinal surgeons. I have a case I would like to share the screen. Is that okay? Can you allow me to do that? Perfect. Thank you. So yes, as you said, this is also a case of a patient that had a tumor. Obviously, I would like to recognize my ocular oncology fellow, who's also a vitreoretinal surgeon, Dr. Nathan Scott, who's working this year with me at Bascom Palmer. And I'm very, very pleased to have this opportunity to kind of improve his training in the niche area of ocular oncology. So this is a 76-year-old man that had a ciliochoroidal melanoma in the left eye, and he had prior peripheral laser for a retinal tear many, many years ago. He presented with moderate lens opacity, and his baseline visual acuity was 20/50. So I'm going to start sharing my video with you now. I hope you can all see. So this is the initial presentation. You see a large tumor temporally. This is 1 month after plaque, and this is 2 months after plaque. And I'm going to pause this real quickly here. As you can see, a very significant tumor regression there. And you can see the star fold, and you can see the laser now is showing up a lot more prominently. And this, this very quick progression prompted us to take the patient to the operating room and perform actually combined surgery. We did his cataract first, and you could see there the little corneal suture, and then we're moving on to doing the vitrectomy and trying to clean up the vitreous, very, very dense vitreous, partially attached. And you can see they're doing a very thorough cleanup of the base of the vitreous where the tumor is. And that is something that I like to do. I think that these tumor cases, if you don't clean the base of the vitreous, it really does not progress very well. And then when we do that, we see finally that there is a little hole in the area that we had thought was completely sealed. As the tumor regressed, quickly opened that hole again. So there we're starting to, we lifted the vitreous and we're starting to manage that star fold with the loop. We're just kind of scraping and lifting that tissue away. And you see there, we're trying to be very careful, obviously very close to the fovea, but also making sure that we handle and we remove everything. See if I can go a little faster. There, so, and then we decided that we would really bring out this removal of this epiretinal tissue all the way to the periphery. Because again, these eyes that we radiate, they become very inflamed and they are very prone to development of PVR. So you see that we're really being very thorough there. Again, going back with the loop until we feel that we got all that tissue. And then we just went there and started aspirating that subretinal fluid until the retina finally started settling down. We put some PFO to make sure that we got everything cleared out. And then laser, obviously not just around the old laser and the initial retinal tear, but also surrounding the base of the tumor and extending into the periphery, as you can see there. Then air fluid exchange followed, as you can see right there. And after that, we went on to give them a silicone oil tamponade. This is 1 day post-op. This is 1 week post-op. And the patient is doing great. We're right now 3 weeks out. This is the OCT at 1 week post-op. And you can see the macula looks pretty good. And then we have the case to discuss in terms of, I guess the next one, quick tumor progression or regression, comes with increased exudation. And in this case, because of the old retinal tear, it really kind of released that retina and it allowed the retinal tear to open, which is kind of a rare presentation. The impact of PVR and radiation to final visual acuity is something that we need to consider. And then begs the question, should we be thinking about additional intravitreal medications during the time with the silicone oil tamponade? Does anybody use methotrexate to try to prevent PVR? Would anybody suggest, putting steroids in the eye, that sort of thing? And how long to leave the silicone oil tamponade? I would like to hear your thoughts and comments about that. Thank you. And I'll stop sharing now.
Nice case and difficult, tough decisions. You have any idea how would you manage that, Yoshihiro?
I think that was beautiful surgeries, Elia. Thanks so much for sharing. And I think these cases can be challenging where there are many more levels that you have to consider than the typical patient. I think because of the visual, you have to think of the visual potential of the patient in terms of if they have radiation retinopathy yet or not. And here, I think this was a pretty acute change in the eye's condition after the plaque therapy. And I assume that the biggest risk factor was the exudation that happened after the plaque. Do you think that's the biggest risk factor? I was curious about, what you think the other risk factors potentially can be, because exudative detachment after tumor treatment, I think it's pretty normal, but retmatogenous is relatively rare.
Well, I think it's a combination. I think it was the fact that the tumor regressed very quickly. That definitely had a significant toll because the tumor in itself progressed right at the edge of that old retinal tear. And so when the tumor regressed very quickly, that that attachment between the retina and the choroid released, although it had been there for many, many years. It's the first time I've seen something like that. So much so that when I saw him 1 week post-op, I was like, yeah, you know, let's just sit it out, because this is going to reabsorb. I was very confident the exudative retinal detachment was going to go away. But then on month 2, when I saw that star fold, I said, hey, wait a minute. And I did not see the tear until we were, you know, in the vitrectomy proper. That's when I realized, I said, oh my goodness, you know, here's here's the tear, you know, this is the old tear, just opened up from the quick tumor regression. So you're absolutely right that, you know, that increased exudation after plaque is a fact, and it usually goes away. However, we see a number of patients, usually younger patients, that have a profound exudative retinal detachment that many times, if you don't address surgically, it won't reattach. And I'm becoming more and more aggressive about those with very promising results. So because these were eyes before that would progress into a blind, painful eye, you know, that exudative retinal detachment would never go away. You know, patient would develop retinal ischemia, and then it kind of like a little domino effect, you know, and pretty soon that's it. You can't go back on that one.
Yeah, that's a great point.
But I think it's the combination. However, you know, my questions were, because this is so early, we're not even 3 months after the radiation. This is a very peripheral tumor. Would anybody think about doing something to sort of prevent, or, you know, be one step ahead of radiation retinopathy, of, you know, kind of new PVR? I mean, this is a patient with a high risk factor for PVR, you know, with the star fold and all that. So I just wanted to hear your thoughts, because I have such a focused view with the tumors, and I always like to kind of just brainstorm and think about that.
Celia, can I have a say on that?
Absolutely, please do.
First of all, thank you for sharing such interesting. I never see the tumor not to work like a buckle. This is a tumor buckle. And usually when we have a buckle that has to be moved for any reason, a single buckle, there's always a chance to reopen the hole, especially if you have this issue of inflammation and mobility of the retina. So if you have already something that you know of, like the laser that you did before, if you can reapply, for example, gas and laser on the same tear when you make the tumor less, it's like removing a buckle. It's like moving a buckle away, that it was closing this hole. The second thing, if the hole is open, it's going to perform a PVR. So it's no reason to go for the second thing. We have to stop it on the first step. And the question about silicone oil, not for this case, but in general, my idea of silicone oil now is that I don't put a time limit on silicone oil, especially when I started using 5,700 centistoke silicone oil. I've seen cases, trauma cases, that I couldn't remove the silicone oil for 7 years, over 5 years, and they're still working. So it's not an issue as before. 6 months you have to remove the silicone oil, 1 month you have to remove the silicone oil, especially if you use this kind of silicone oil. And that's about it.
Those are good comments. You know, obviously nobody can anticipate how quickly a tumor is going to regress. It's a very variable thing. So sometimes we may see a tumor that, you know, 2 years out, you still have that elevation and that buckle effect. So it, you know, to remove a plaque and immediately inject gas and laser, in this case, I don't think it would be applicable, especially because his vitreous was still attached, surprisingly. So that probably would not have worked well. So I think that, you know, at this point, my question is more, what do you all think are the risks for, you know, PVR again? The patient is really well attached. I mean, I don't see any problems. I did not do a buckle because, you know, I had already radiated that area and I didn't want to open it again and pass sutures through the sclera that had been radiated. It's a very fragile sclera. The chances of scleral tear and you know, kind of opening a brand new can of worms are very high. So that was the idea. And I did go ahead with the 5,000 silicone oil. I usually have kind of a rule of thumb that I leave the oil in for these tumor cases for at least 6 months, but more kind of towards a year out. So I'm very, very patient. And I keep them in a very low dose topical steroid, you know, just like Fred Forte, maybe once or twice a day, just to keep the eye really calm, because I say that, you know, long term, what these eyes really need is stability. And, you know, once you guys address these kind of questions or dilemmas, then I think that the case is pretty well settled. Thank you.
I think, Zelia, because the patient has surgery with you, the risk for PVR is close to 0, and patient's going to do awesome. And you were also alluding earlier into possible preventative treatments. I think you were alluding to possible pharmacological intervention.
Yes, yes.
So, you know, you have, I think, two different options that I think you and I are thinking about. Like, you have methotrexate is one that's been currently being studied in phase 3 studies. And, you know, I use it for some patients also. I think it's a good option. I'm not sure how well the eye is going to tolerate it. I'm not sure about the efficacy of methotrexate for tumors in general. You can tell us more about that. But another really interesting thing that I think would fit here would be anti-VEGF agents. One, there are many papers showing the effects of anti-VEGF agents to prevent radiation retinopathy and maculopathy. And there's a prospective DRCR study being planned for that. And there's also prospective studies looking at anti-VEGF to prevent PVR now also. So we don't have like final data regarding definitive data regarding PVR, although in preclinical animal studies, it looks very promising. More data regarding prevention of radiation retinopathy, but the two might fit well together.
Thank you. I've used both, and I've used quite a bit of methotrexate in these eyes, 1 injection monthly. And, I've never had recurrence of PVR, more, sort of maybe to treat my own head than anything else. And the anti-VEGF does really help. However, I've noticed for the eyes that have refractory macular edema that are unresponsive to anti-VEGF and all that, under oil, Ozurdex works really well. So maybe next time, if I get invited back, I'll show you guys a series of those cases where, I put a bunch of different drugs for different reasons, but it turned out pretty well. And I agree. I mean, there's no definitive data, and that's why I wanted to hear your experiences. Thank you.
Yeah, I think you managed the case very well. And I think the problem is, as you mentioned, this is a young patient, and that's why the propensity to get the problem with the PVR and tractions. And we see that in the younger children, like in the retinoblastoma cases, that we treat them with chemo, cryo, and all that actually settle the tumor, but then we very often get problems with PVR traction and rhegmatogenous detachment at the basis of the calcific tumor. And I think it's the same mechanism. I think the idea of treating or the radiation retinopathy, you can't really prevent it. I think if they develop it, you manage it. If they happen to not suffer from it, then just watch it. I think having some anti-inflammatory along the way can help. Even maybe put them on a low dose of or maintenance dose of non-steroidal anti-inflammatory may potentially helpful.
Very good. Thank you. Thank you so much for the opportunity to present this case. Appreciate it.
And, as I said in the last meeting, Retinawesome 10, we are a little afraid of moving forward in vitreoretinal surgery when we face, tumors and this kind of stuff. And you manage that so well that we get more pleased and more looking forward to doing more and more vitrectomies. And thank you very much for sharing your case. And I was missing somebody from last talk after Dr. Lam is Anthony Mack from Hong Kong. It's always a pleasure to have the residents and fellows from other countries. And Hong Kong, for me, he was with Dr. Lam. He is there all this time, and yeah, of course, a good professor teaches very good knowledge. So, Dr. Wai-Chim Lam, please introduce us to Anthony Mack.
So, Anthony is our fellow in the retina group, and he's one of our more junior staff. And thank you, Hudson, for the extending invitations. So he's sharing a medical case and not a surgical case. And perhaps the next time, if he gets invited again, he will share with you with a medical case. So Anthony, why don't you go ahead to share screen? Can he share screen, Hudson?
Yes.
I think so.
Okay. So it is not the usual case, right? So it's an atypical presentation. So beware of the traps.
Can everyone see my screen and hear me?
Yes, loud and clear.
Yes, okay.
Oh, by the way,
Great.
I just want to add a little piece, is that Anthony actually is in the call room in the Queen Mary Hospital. He just got called in to look at a retinal detachment case. So instead of going home after seeing the case, he actually stayed at the call room so that he can do these presentations. So thank you, Anthony.
Thank you, Prof. Lam. Yeah, I was worried that if I share my video, it might consume some bandwidth and slow down my internet. So I'm sorry, I'm not sharing my screen, my video at the moment. Bom dia, obrigado pela oportunidade. Thank you for having me here. Very grateful. So I have an interesting medical retina case. It's a 67-year-old lady presenting with a few-month history of blurring of vision. She initially saw a private ophthalmologist, which diagnosed her with a CSCR, or central serous chorioretinopathy, in the left eye. And she was referred to us for PDT treatment. She's not known to be on any form of steroids. On examination, her visual acuity in the right eye was 20/30. In the complaint eye, the left eye was 20/60. The intraocular pressures were normal in both eyes. Anterior segment examination was normal, unremarkable, quiet anterior chamber, and she was pseudophakic. So on the fundal examination, we have some fundus photos. In the right eye, we can see top left to center on the disc. There is a couple of retinal hemorrhages. Inferior to this, there's a small splint hemorrhage and also a blot hemorrhage infranasally, and also something that appears to be a cotton wool spot just temporal to the disc. And then on the left eye, the most striking abnormality in the bottom right image, we can see a whitish creamy lesion over the supratemporal area, over the supratemporal arcade, with some white dots over that lesion. I think it's fairly well demarcated, and there's some subretinal fluid involving the fovea, which is not very clearly seen here, and also over that lesion. There's also a small splint hemorrhage temporal to the disc in the left eye. So we proceeded to perform some multimodal imaging. I apologize for the quality of the images. Can't see the inferior part of both eyes very well. I think those are more like artifacts. That same lesion has a hypo autofluorescence with a surrounding hyper autofluorescence, and also some within that lesion there is some hypo autofluorescence corresponding to the white dots that we saw earlier. There's no lesions on the right eye. And then this is the OCT macula of the right eye, which is unremarkable on the vertical and horizontal cut. And this is the complaint eye. So we can see subretinal fluid and some hyperreflective deposits involving the fovea. And then on the vertical cut, I'd like to open to the floor to see if anyone has any
anyone have any comments on the OCT at this point? Anthony, can you move up to the next slide with the multiple?
Yes, I'll move up to the next slide. So this is the OCT of the left eye, showing the 19 raster scans. So again, we can see subretinal fluid involving the fovea. On the top left, which is superior macular region, we can see a little bit of undulated choroidal elevation, but it's not as obvious as the vertical cut here, where we can see in the bottom right of the screen, there's a little bit of a choroidal elevation there. And I'd just like to take this opportunity to comment on the whether there's any pachychoroid, which I think is borderline in this case. It's roughly the similar thickness as the retina, and that's the case for both eyes. So we proceeded to perform angiography, obviously. For the right eye, on the ICG, there is no hotspots, and in the late ICG, there's some non-specific hypersenescence over the posterior pole. And then on the FA, we can see some microvascular changes along the ST and IT infratemporal arcades, but otherwise no leakage in the right eye. And then for the left eye, the eye that we're interested in, on the ICG angiography, we can see this blockage over that lesion that we were looking at in the supratemporal region throughout the transit. And then on the FFA, we can see multifocal pinpoint hyperfluorescence over that lesion with progressive leakage over that transit. And if we look carefully, there's actually something going on also in the infratemporal region as well. There are some foci of hyperfluorescence, and also a relative area of hypofluorescence. If you squint a little bit over the infratemporal arcade with a rim, a very sort of smooth rim of hyperfluorescence. So this may or may not be something, but on the OCT, unfortunately, we didn't manage to scan that area. So just zooming in on me, that didn't look very typical of a CSCR. So on further questioning, this patient is actually suffering from breast cancer with a widespread bone and lymph node metastasis. And she actually had a PET CT done last month showing metastatic axillary lymph nodes and widespread disseminated lytic bone lesions. She's actually on target therapy called ribociclib and also letrozole, which is a hormonal therapy. However, on the PET CT, they didn't mention any hypermetabolic lesions over the globe. So I proceeded to perform a B scan, and this is directed at the left eye, the area of interest around the supratemporal region. And we can see a very subtle plaque-like elevation in the choroid in that area, but no subretinal fluid was obvious on the B scan. So at this stage, I suspected that this lady might be suffering from choroidal metastasis from the breast cancer. So I referred her back to the oncology clinic, and she had an urgent MRI brain and orbit done. And on the report, there was some linear enhancement at the posterior pole, posterior aspect of the globe, with possibility of choroidal metastasis, although the report was not very conclusive. So the oncologist actually offered the patient external beam radiotherapy, but the patient declined. And the patient was actually just started on that target therapy, and she wanted to persist with that. And she also wasn't keen on any form of local treatment. So this is an image from that MRI that she had done. So on the left eye, we can see that subtle area of choroidal thickening. So just for our panel discussion, I thought this was an interesting case as choroidal metastasis mimicking as a CSCR. It is an underdiagnosed condition, and I think diagnosis can be challenging sometimes in these patients. In this patient, she had a history of breast cancer, so and together with the multimodal imaging, clinically it was suspicious of a metastasis. So I just like to get some expert opinion on this subject, on anyone's local experience of diagnosing and managing choroidal metastasis. Thank you very much.
We have a perfect expert. Zalia is in the participants. I think I luck out to have her to be in the group, so she can share her opinion on this case.
of external beam radiation, and as opposed to intraarterial therapy. What are your thoughts on that?
I think for the metastasis, they use external beam to manage those cases. I don't think intraarterial mechanisms works as well for this type of metastasis. Yeah. Or just actually the crew were in the OCT. The OCT over the lesions actually show a solid lesion. They obscure the choroidal vasculature. It begs us to sometimes look at all the scan that comes to you, and then not to miss or not to ignore features. The vertical scan, we're actually picking up that area. And if one take the time to look at it, you realize that there is abnormal choroidal lesions in their locations, and everything we're pointing to there's something abnormal there, including the fundus autofluorescence and the subsequent angiogram, and of course the background history helps. So I think the importance of getting histories and looking at all the information that's provided to you, and not to just discount things and assuming the common. It's just interesting. The patient was actually sent to us to do the photodynamic therapy because we have the facility to do it, and we does it for central serous. In Hong Kong, that is the most common or standard treatment for central serous choroidopathy, using half dose or half fluence.
Dr. Lam, just a comment, sorry. Excellent case, and I think there's a very good diagnosis you picked up in that particular case by Dr. Anthony as well. And the superior left OCT, that undulations, would you call that the lumpy, bumpy retina that has the typical appearance, the slight elevation, not too much, but it's got that jagged appearance with RPE lifting up and down. That make you?
Yeah, I don't know. I think I'll leave that to Zelia, who probably has seen a lot more of these cases than myself. The lumpy dumpy, all I can describe to you is that there are some abnormal RPE over the area, and then there's a very mild elevations, and on the OCT, the choroidal vasculature is obscure. So that tells us that there's abnormal infiltrate there.
Let me say something. I think that we don't have to forget the other eyes. The patient have a lot of lesions in the choroid, like central serous retinopathy. I would like to know with Zelia if this can happen when the patient have metastasis.
It is a very interesting comment, and my answer is, although we know that metastases seem to be, as described, more lumpy, bumpy, more of that wavy pattern, we can see sometimes diffuse tumors that will grow in separate areas and do create a pseudo appearance of metastasis. But the thing that really distinguishes the metastasis is that really kind of very what they call, the seasick kind of appearance, and the very swollen photoreceptors and all that. But more than that, to address the question about the centroserous aspect in the other eye, is that patients undergoing treatment for metastatic disease, they can have very small metastatic foci that will regress, and then they will pop up elsewhere. So these could very well be, I'm not saying that that's what they are, but they could be pseudo-central serous that were old foci of metastasis, because we know that the data we have in terms of metastatic carcinoma to the eye It is, it's not very good. I'm sorry, I just got a message here. It's not very good because this was before the era of immunotherapy. This was before the era of, advanced chemotherapy. And now we're seeing much more, evolved or much more acute or severe cases that we wouldn't see before because the patients would die. So I think metastatic disease is really kind of coming to a different level. And also we're seeing a lot of complications from the treatments, the systemic treatments that these patients are getting. So those are my comments. I think that having the CSR appearance in the other eye does not rule out metastasis. On the contrary, it could somewhat endorse it in terms of the systemic treatment. So I didn't catch if the patient had gotten any systemic treatment during or right before the ocular presentation.
Yeah, she was receiving target therapy with a couple of drugs, and so that could be a medication-induced changes also. Yes.
Again, Anthony Mack and Dr. Lam for such good cases, both clinical and surgical, and that's what we are looking at for the next Retinawesome in Cordoba. And we're going to have these young retina specialists also showing great cases in vitreoretinal surgery and the clinical cases as well. Thank you, Anthony, again for your participation. And I want to call Dr. Professor S. Natarajan, honor to have you here for Retinawesome 11. We are since the beginning, and you are free to show your case, Natarajan.
Thank you, Hudson, and I enjoyed Zelia and all the presentation. Hi, Yoshi, how are you? Professor Francine.
Nice to see you, Dr. Natarajan.
Yes, and we have to work on the rotary on prevention of ocular trauma. So, I'm sharing. Yes. I'm sharing. So here I have a case of pediatric chronic retinal detachment with a white cataract. So this was a 6-year-old boy from rural part of Maharashtra, where like about 200 kilometers from there he came. The parents noticed that his eyes appear white with leukopenia, white reflex in right eye since 20 days. Sought opinion from local ophthalmologists who referred the patient to a higher center to our hospital. The history had normal birth history, no history of premature delivery, no consanguinity in parents, no significant family history, and the child was refusing any history of ocular trauma and no evidence of any developmental neurological signs. So there was a normal head posture and alignment, no nystagmus. Preoperative in the right eye was light perception with the projection of light in all quadrants. Left eye had 6, 6, and 6. Finding by slit-lamp examination and indirect ophthalmoscopy. OD external eye was normal. Pupil was reactive to light. White cataract noted, and receptor was quiet. No cells could be visualized. Poor view due to cataract. And left eye had anterior posterior segment normal with healthy disc and retina. The plan was to do a right eye B scan to assess the retina, and then we then decided, and the B scan showed a total bullous retinal detachment, and this was the preoperative cataract. And I could see through this cataract some through the indirect ophthalmoscope like a retinal detachment. That was the fundus view taken in the fundus camera, and this was actually a fundus seen intraoperatively after removing the cataract and placing the intraocular lens by my colleague Dr. Kavita Rao. So I'll just show you the surgery. So I'm actually planned a 360-degree peritomy, and we planned a phaco IOL and a vitrectomy and a belt buckle. So before the cataract surgeon does it, I don't do the cataract part. So I do a peritomy, tag the muscles, and because of the young child, it was a full, the tenon was quite sticky, and so we have to make sure we tag all the 4 recti, and then make a belt buckle, make a scleral flaps like a belt loop, and then pass the 240 band, and also use the Watsky sleeve to tighten the buckle. So before the cataract surgery, I don't tighten, and here I'm making using the hockey stick knife, and which we used to do the scleral implant, trained by Dr. Charles Keepens. My mentor was trained by Dr. Keepens, so we learned from that, and then using the bobbing technique, make this all the 4 quadrants, and pass the 240 band, make it like an arrow, cut it, and then pass it all around, and then the 2 ends are actually no sutures, and then you use the Watsky sleeve to keep the 2 ends. You can see that. So you can put, this is a Watsky sleeve, so it will hold the 240 band, and then you can tighten it. So that's the 4th step. So you can see that at present we are not tightening it, and then the cataract surgeon takes over, uses the brilliant blue to stain the anterior capsule, does the capsulotomy, and then she was mentioning to me that the cataract was membranous and it was not like a regular cataract. We don't know why, still don't know what's the reason why the cataract was like that. And see, you can see a thick membranous anterior capsule. She will actually, after cleaning, using the vitreous scissors, trimming using the forceps and then scissors, and now she placed the foldable intraocular lens. And so during the surgery, just to keep the antechamber in position, we actually put 1 suture, and then she makes sure that the AC is clear. And then now I enter with a 25 gauge 3-port pars plana vitrectomy, and you can see now I perform the vitrectomy, and then while after doing little vitrectomy, I tighten the buckle so that the peripheral retina will come into view, and you don't have to need the scleral depression using a cotton tip applicator. You can use the 240 band, and you can see the bullet detachment. And in spite of having a complicated cataract with a bullet detachment, you can see retina was freely mobile. And then I'm using the perfluorocarbon liquid, squeezing out the subretinal fluid, and then I should be able to see the peripheral retinal bag, and that was the cause of the retinal detachment. And surprisingly, the patient did not have any symptom of reduction in vision, because he didn't probably notice that one eye was having. You can see the scleron, the optical phenomenon of subretinal fluid coming out, and you can see the retina totally getting attached, and then you can see the buckle effect, and you can see the peripheral retinal break, and I do a endolaser photocoagulation around the retinal break. And the whole idea is and at present the buckle height is a little higher because of I've tightened the buckle just to see the periphery and complete the vitreous base excision. So a thorough 4 to 5 layers of the break is surrounded with the endolaser, and then I do a PFCL air exchange, and then I do an air oil exchange. So and at present under the PFCL is removed, and I'm doing an endo drainage using the retinal brush, and make sure the retina is totally flat, and then the break is anterior to the belt buckle which is placed, and make sure that now I can moderately tight or loosen depending on and at present the PFCL is removed, and the entire view is through the air, and make sure that the retina is totally attached, and the last drop near the optic disc is removed. And this is a view through the 3D microscope, but you have a 2D visualization to demonstrate. I hope one day we can transmit 3D events so all of us can wear 3D glasses and see. But as Dr. Thanasis Nikolakopoulos mentioned, that everybody can see what you are doing, and that's the advantage of using the 3D surgery. And at present, the air is being removed when the silicone oil is filled already. And make sure that the intraocular pressure is fine, and then remove the 25 gauge ports, and then trim the 240 band, and then I do a subtenon antibiotic wash of the silicone buckle which is put, then cut the sutures and remove it off, and then use the glue to close the conjunctiva so that it can be a total sutureless surgery. And in case you want to remove the anterior suture, you can remove at the same time or a little later. And here you can see, being a young child, the tenons is popping out, but I'm using the glue so that the conjunctiva and is totally adherent to the sclera, and make sure that the belt buckle is covered to avoid buccal exposure or buccal infection. So, and then I also give a subconjunctival antibiotic injection to make sure that the buccal infection doesn't happen. And so this is the end of the surgery. You'll be seeing under because usually the media is clear, and sometimes there's a subconjunctival antibiotic injection, some amount of and you see the post-operative day 1 attached retina under the silicone oil. You can see the silicone oil bubble, and the child, the temporary vision, he had about 2 meter vision post surgery. So the discussion is what could be the cause for a unilateral white cataract with spontaneous retinal detachment in a 6-year-old with no significant systemic or family history, and looks like there's no myopia, and I know there was a peripheral retinal break pre-existing. So I don't know what's the cause, but we managed it well. Thank you very much.
In the audience, and of course, he's invited for the next meetings as well.
Hi, Hudson. Good to hear about you. Nuti is a great friend and great retina specialist. I'm very proud with everything he has done, not only in India, but Nuti is a world star. He's spread retina all over the world. And it's a beautiful case. And I'm agreed that buccal, it's very important to young fellows, but I also used to still placing buckles in many cases. And I think it's a very used tool. And he did it beautifully. And I do the same. But most of the times I just use gas. And sometimes I laser more when I have only a small break and I think that has something that I'm losing, I just try to laser 360. But a beautiful case. And Hudson, congratulations. Your Retinawesome is growing bigger and bigger, and I'm very happy to stay here with you. Thank you very much.
You are always welcome.
Thank you, George. And so Hudson, even I was tempted to do the buckling if a Thanasis showed a patient and removed the subretinal band. I always felt the subretinal band does not behave like the epiretinal band, which is usually PVR is contracted. So I have old detachments. I've done scleral buckle, do a subretinal drainage. If the band does not cross the macula and if it is in the periphery, I just do a scleral buckling with a drainage, and I just inject a 0.3 like a pneumoretinopexy gas, and if required I position. But I think I love scleral buckling, and any fresh detachment I still don't do vitrectomy. I'm an aggressive vitreoretinal surgeon, but at the same time I keep learning from Dr. Jovanovich and Dr. Skipens when not to do some procedure. I think today also somebody had a epiretinal membrane with a lamellar macular hole. The vision was 20/40, but patient is an old lady, other eye 20/20, and no problem in vision. So I told them, come back 1 month later, and patient said there's no complaint. And even on Amsler, no complaint. So I think if you just see the OCT, you have to do surgery. And the same thing for the subretinal band. which I still feel, I know, unless you see the patient and you don't know how the retina reacts. And Thanasis demonstrated that it did not settle, so I had to remove the subretinal band. But I have done many cases. I would probably have to publish that scleral buckling with only subretinal band, nothing in the, because the vitreous was not detached. That's what he showed. And when vitreous is not detached, I prefer a scleral buckling over a vitrectomy buckling.
Nuti, I agree completely with you. And I would like also to add, Dr. Atanasio, something like 3 months ago, live, he just told a very true word. He said the people don't like to use buckle just because it's not cosmetical, but it's simple, is low price, and very effective in many cases. And I agree with you, even with subretinal bands, sometimes this place a good buckle gonna do well and the retina is attached forever. And when you have a young patient with vitreous attacks, is the best tool that ever we can do for the patients is placing a buckle.
Yeah, I agree with you, George. And I think that's why I think the principle and practice of surgery I want to write. I made a book this year with the Springers on cutting edge vitreoretinal surgery, but still, I think whatever is here, I'm not able to get it. That's what Thanasis is doing in the Thessaloniki Vitreoretinal School. But I all the time tell the surgeon they only watch the fellows watch the hand, but they can't watch what's here. And that's what I think we have to learn from Professor Eugenio Medeiros, who's here, the senior surgeon, and George Mitre and Thanasis. And I think I don't know how to do it. I mean, everybody, I'm glad all are appreciating the surgery, but I think how do we convey to the young ones? And I think all of us were young one day, and we are doing beautiful now. But how did we learn from our mentors is what I think is the technology transfer, which Dr. Thanasis is a great work he's doing. And as he said, here the fellows learn directly from the patients. And so I don't know how to do that, because this is what I don't know. When to do buckle and when not to do a buckle is an art. And I think that's why I call it a fine art of scleral buckling surgery. And that's why I keep writing. And it's not a forgotten science. And second, I'm trying to analyze, I think I'm doing 37 years now, scleral buckling. So, and I think I still know how to do it. And your comment on cosmetic, I am about 5 years back, I was doing an instruction course in vitreoretinal on the buckling, pneumoretinopexy, primary vitrectomy. I forgot who was the surgeon who asked me. He said, if an actress comes, will you do a buckle or a pneumoretinopexy or a vitrectomy, primary vitrectomy? I said, I'll do buckle, because I know my tissue handling is excellent, and I don't think there's any cosmetic problem, touch wood. I think rarely I've seen any squint, and that's why I want to analyze my own series, no squint. And I think if at all, I think if you do the tissue care well, which is what I learned, whether it's conjunctiva or subtenons or whether it's cornea, I think, yeah, that's why I never use ringer lactate or even BSS to wet the cornea. I just use the viscoelastic or continuously on the cornea. So I think if you learn tissue care, next day the eye does not look like you're operated. In 84, when we are doing surgery, next day you can't see, open the eye. It'll be totally swollen because you've handled the eye for 6 hours. I still don't know what I was doing inside the eye for 6 hours. And Dr. Skipens and Dr. Hal Freeman, Dr. Tatsu Hirose, I think my teacher is trained by Charles Skipens. And they all were doing 6 hours and 8 hours. I don't blame them, but I've learned from them. But now I do in half an hour. And sometimes Fernando Arbiello was there for a live surgery. And I did a PVR and giant tear in 20 minutes. And nothing hurry-burry. And I always tell them that what you think, and if you do the step, there's nothing to do fast. Everything goes well.
Listen, Nati, I really appreciate that you're doing such a great job. And when I saw the video, but before 2 years, we did in TVRS a buccal wet lab, and we thought that this was an obsolete thing. So we asked Cavitabile, who is from Italy, and Repucci from United States, who were experienced in buckling surgery, to show them how to do buckles and what's pro and what's against it and everything. And at the end, you know that the people in TVRS, they are voting for the best teaching and what they like most. So it was not episcleral surgery. It was not anything. They voted for the buccal surgery because that was the first time they saw buccal surgery in their life. And they saw how simple it is. And I used to say that if you don't know anything about retinal detachment, and you got a phakic retinal detachment or ILL retinal detachment, and you don't know how to see the eye, you don't know how to do cryo, you don't know anything, take a 3mm sponge, go behind the muscles, just tie it at the end without making shorter because it's a little bit dangerous, and leave it like that. It's 50% without cryo, without doing anything else, that the retina is going to settle down because with multiple small holes around the periphery, that would be just enough. So when they saw what the effect of the buccal, when to use it, how to use it, and everything like that, how easy it is if you just be very careful with the conjunctiva, which is that's what makes the eye swollen. If you are taking care of cryo, because a lot of heavy cryo can produce a lot of swelling in the eye. And if you don't tie the buccal very tight, you don't just, then those three things, if you avoid those three things, you got a beautiful white eye at the end of the operation. So don't worry. And you keep the lens intact. So that's another issue you have to know. So that's why every year now, and we'll have you this year, I hope you'll come with us. We're going to have a session about buccal surgery in the wet lab.
That's what I wrote to you yesterday. I would like to teach scleral buckling.
But please bring some 3mm buccal sponges, because we don't have any more in Greece. There's nobody selling it. I have to import them from Romania. Nobody's selling buckles in Greece anymore. It's inexpensive. It's €5 each. It's inexpensive. Nobody's using them, so they don't bring them. But they bring €600 for a set of vitrectomy, which is everybody's selling.
Yeah,
so,
I want to thank all the people who are still teaching buccal, because I think it is an important procedure, and it will soon become a lost art if we don't keep teaching it to our younger generation. So everyone here who are doing their job teaching the younger generations this type of surgery is a gift to the next generations.
Yes, and actually a gift to the patient. This is what I keep telling them. You learn to do buccal well. That means you learn indirect ophthalmoscopy. And I think that the art of doing retinal drawing, which was given in Highlights of Ophthalmology, again by Benjamin Boyd from South America, the great contribution by Rosenthal, who wrote the article in, I think, 1967. I think it still holds good. It is part of my fellows' manual in our fellowship, and they have to go through that, and also the surgical self-education by Steve Charles, and also the first chapter of Stallard's book, again written in 1946. It still holds good because you should learn instruments, you should learn the tissue handling, and finally you learn the principle, which everybody only fascinated with the surgery. And I agree that the result speaks. So I think the patients have to see, and this is what I think Charles Keepens and Jovanovich was teaching, which I'm glad Wai-Ching Lam also is telling the students, and we have to tell them. I think that finally we are doing this entire meeting is only for patients. And I tell them, because of patients, they're all traveling all over the world.
A great obstacle in buccal surgery is that new fellows don't know anything about indirect ophthalmoscopy. But now the great opening for buccal surgery is that you can do it with endoillumination, like you do the vitrectomy, but just put a trocar with endoillumination, and you don't need an indirect ophthalmoscope. So if you remove this obstacle of the indirect ophthalmoscope and do the buccal surgery with the endoillumination 25 gauge or 27 gauge, then because you have the microscope and you have things that they are enlarged a lot, with the indirect ophthalmoscope, you have to be a master to find all the holes, all the tips and everything like that. So I think the indirect is a lost art, and it's going to get obsolete, but the trocar light is going to be there, because now with 30 gauge and 27 gauge trocar light, it's like injecting an Avastin. It's nothing to put a light inside. You don't even need a trocar. You can just put it like that. So I don't know what's the opinion of other people who are using buckles, if they're teaching people how to do it with the endoillumination. or if they're still using the indirect ophthalmoscope. That's what I'm asking.
Dana says, I agree with you. Only thing you have changed little, because I'm somehow still don't recommend the putting the light. It is like learning indirect is one step of retina which they should know. I know we have to use the slit lamp biomicroscopy, use all types of lens. I will tell you, last week we had a patient, one eye operated by my mentor, Dr. Badrinath, in 1984 or something, and then the other eye I operated in 86 again in Madras. You know what he came and told me? The patient told me, doctor, nowadays nobody knows how to check retina. You people were checking the night before, 1.5, 2 hours, and you are sweating to find out every part of the retina and mapping. Nowadays, they take a pan photoscope photograph or a wide-angle photograph, and they say they have done retina photograph and retina diagram, but nothing like doing a retinal drawing. And I think if the fellow learns even today with all the modern gadgets of Heidelberg or wide-angle OCT, wide-angle photograph, and still, I think instead of using the endo-illuminator, I suggest we should not bow down to the youngsters so much. I'm sure a lot of youth are here. I actually have now a fan club of 10-year-old and 12-year who are operated by me, and I have a retinoblastoma girl at the age of 1, enucleated one eye and then the other eye. So I'm actually having a fan club which I inspire them to do something great in life, or somebody who's not got vision. So what I want to tell is, Tana says, we should encourage, even though indirect maybe not required, but I think we should learn indirect as one step in retina, apart from OCT angio, and all sorts of OCT, and then the 3D surgery. I think the basics is very important.
You are a very passionate man. You are a retina garden. You are not a retina man. You are a retina garden. You have all the flowers under your auspices. Congratulations again. Always surprised me for being so young, for being so thin, and keep like that, please. Stay like that.
Yeah, I agree. I think we need to treat we need to train surgeons, not technicians. So I think if we keep at what we're doing, then we will get good surgeons, and who will look after us. And technicians are important, but they don't think. That's the difference.
I'm saying this is how to convey this is what every day I tell my people. So please discuss the day before. So we do that. As I said, in management, they have this SWOT analysis and all that. I said, why not we do that in day-to-day practice? So even today, I have a drawing check the day before, which looks odd that my fellows grumble. I said, no, I'll finish my OPD. I want to see what is my list tomorrow. I want to know what's the plan. I have a plan of action, and it'll change during the surgery. I said, learn that. That's what is the logarithm. And that's why when Steve Charles introduced that logarithm, even though you had all the idea, okay, you have a subretinal band, do this, you have a epiretinal membrane, you do this, but still, I think it's like playing soccer. Nobody can tell that, no coach can teach the guy who's going to put a goal, do the shot like this. You have to anticipate and then do it. And that's what I want to learn from the teachers here, how to teach the young people and inspire them to learn indirect ophthalmoscopy. As he said, I'm a real passionate, I don't mind operating from today, the whole night I'll operate. And that's what I am doing for the last 39 years, and still I'll do it. I don't know how many years I can, I will do.
Athanasius, but we still have to do more. And I have the honor to call Dr. Yoshihiro Yonakawa from Will's Eye Institute. It's great to have you here again, Yoshihiro. You are always teaching us, and we are glad that you came to Retinawesome 11.
Yes, thank you so much. It's an honor here. And I apologize, this is not a buckle case, but I assure you that we do a lot of buckling at Wills, and our fellows graduate with hundreds of buckle cases. So this is a child, and in kids, you want to think about scleral buckle always in rhegmatogenous detachments and some tractional detachments also that are focal in nature. But when you have a complete retinal detachment that's tractional, usually you have to do vitrectomy. And this is about first time showing this video. It's a 6-month-old who was referred. Actually, he came through our emergency room with leukocoria, and there was a concern for bilateral retinal blastoma versus codes. We're not sure. And then the patient came to my clinic and was found to have bilateral tractional and exudative retinal detachment. And the child also had some systemic issues with developmental delay, and has a diagnosis of deletion of the short arm of the 18th chromosome. And so this is what his eyes look like during the examination under anesthesia. And you can see that this is a total funnel retinal detachment, and the fluorescein shows that you have anomalous vasculature. And so this is a developmental vascular abnormality causing a tractional retinal detachment. And here, I'm going to do a vitrectomy, but very differently than usual. So I make a peritomy, and you can see I have the infusion here through the corneal limbus, because there's retina right behind us, behind the lens. So you don't want to make any iatrogenic breaks. So we make the infusion through the corneal limbus. You can either do a AC maintainer, or I personally prefer just putting the trocar in here because it fits very nicely and very, very snug. And then I make the other incisions through the limbus here as well. Instead of using cannulas. You can put cannulas through the limbus here, but it's gonna just take up too much space in this particular case. We remove the lens because there's fibrous tissue that's attached to it. And this is a very important step here, removing the capsule, because this is what the retina can grow back on and acts as a scaffold. And so we remove the capsule in its entirety very carefully. And then this is the anterior hyaloid that I'm initially dissecting. And you can see retina's right behind it, and debulking the vitreous here using the cutter. And this is an MVR blade that I'm using for a sharp dissection because the tissues were very tight. I have to initiate a plane here using sharp dissection, and then we do dissection and then debulk, dissection, debulk, and I keep working in the center only. And I keep going down and down and down. And as we're doing this, the retina, you can see, is already kind of relaxing already. And the question is similar to what Dr. Natarajan mentioned about sclerobuckling, when to do it, when not to do it. It's also a question here, when to stop operating in these tractional detachments. And so I stop usually when I see that the retina is starting to relax a little more. And when it starts relaxing, it becomes a little more dangerous because everything is more mobile. Also, I put a time limit on myself. And I feel like even for these very complex cases, there's a limit to how long you can concentrate during vitrectomy. I feel like for sclerobuckle cases, you have the luxury of kind of relaxing every now and then, but for vitrectomy, you have to be always really focused. And so I put a time limit to myself also. And here you can see that this is post-op month 1. Actually, no, post-op month 3, the posterior pole has reattached very nicely. And over here in the periphery, the retina is still detached, but I'm okay with that because the peripheral retina is very, very thin, very difficult to dissect, and easy to make iatrogenic breaks. So my approach usually is to just keep digging in the center and going down as far as I can. And then we release the traction, and then the retinal pigment epithelium will pump the fluid out to reattach the retina. But it can take several weeks, couple of months. And this was a very nice outcome. And the other eye was even worse, but because this eye went well, I felt some confidence that I can fix the other eye as well. So we did the same thing. Okay. Would love to hear your thoughts and how you approach these kind of tough total detachment cases.
You have a way of doing things like that. I'm sending them to you.
Me too.
Thank you. That's
You
funny.
gotta have a
Lovely.
volume.
Not too much, not too much.
You gotta have a volume of cases like that. You cannot do every 2 years one case like that, every 3 years a case like that. I do believe in centers, that they must be specialized centers to do specialized things, that they can have a volume that we don't have in everyday life. I don't think it's for every retina surgeon to do surgery like that. I need to have a specialization on focusing on something. And I'll be happy if I have a case, I will send it to you gladly and happily, because you'll do a much better job than I would do myself. I'm sure about it.
Dr.
Yoshihara, you've
Yonekawa,
done a very good job. Beautiful job. Sorry, Francine, you go ahead.
no, I asked, sorry. I was just about to say that Dr. Yonekawa always gets us speechless because these cases are so beautiful and so challenging. And I would like to, I have no experience with child, but I would like to ask you if the retina goes really flat and it stays flat, stay applied, because when I see this, the goal that I have is to approach more, to take more the periphery and try to make it all goes down. But I know I've learned from you that we shouldn't do this. That's what I would like to hear about.
Yeah, it's very tempting to flatten everything, make a retinotomy to drain the fluid, doing a retinectomy to just flatten everything. But the approach is just so different from adult eyes. Adult eyes will be able to tolerate a 360 retinectomy. Ideally, you don't have to if it's a tractional detachment. But in severe PVR or diabetic cases, you can make breaks in the retina to drain fluid or cut traction. It's necessary in adults, but for kids, as long as there's no regmatogenous component, the eye is very resilient. And as long as you release the traction for it, the retina is still very elastic and will reattach. It's really beautiful. This case went really well, and I'm very happy with the outcome. And the patient's vision has improved, and he's functioning with aphakic glasses. However, it doesn't always go like this, and every case is very different. And I think we just have to be very careful about the decision-making process. I think is the most difficult part.
I think you've done a beautiful job. Like this is similar to cases of stage 5 ROP that we used to do. Fortunately, we don't see too often with the anti-VEGF and also better screening. And with the same principle, it is a stage 5 ROP is a tractional and exudative retinal detachment. And you demonstrate beautifully that you don't need to get the retina flat completely. And once you remove the sufficient amount of vitreous tractions, the retina get mobile. And knowing when to quit is critical. And as a VR surgeon, we tend to do more, and the temptations to do more and the ability to stop yourself to try to do more and quit when you are ahead is more an art, and it comes with an experience. And I think you show it very well that you have that experience. And I think just like it was said before, that it's hard to actually tell when to stop because there's no kind of guideline to tell you. You just have to get a feeling that about time. But you mentioned 2 factors and one time element. And with the infusion in the cornea, that also become a problem. Like you get progressive corneal edema as the time of the surgery progresses, and that will compromise your visions and or visualizations, and that also tells you to stop. And also stress to the fellows that don't procrastinate at the beginning. You need to work very diligently to try to deal with the problem at hand. If you you should have some plan in mind. If you take time in the surgery, you'll pay for it because later on in the surgery, you won't be able to see well, everything starts to get blurred, and then you make mistakes. And that's when you really regret the procrastination earlier. So
yeah, beautiful points. Exactly.
Once again, Dr. Yoshihiro, anybody wants to, do you want to comment anything else, Francine? Or we should proceed to the, actually the next case is mine, and I will share my screen. This is an interesting case of a diabetic retinopathy patient. We know that we are presenting quite tough cases today, so outcome switch, because we never, when we wait too long to operate, and sometimes we get those patients that have long-standing diabetic retinopathy. They go on with laser and other treatments, injections, but sometimes they get so proliferative because they are not under so much control, so you have to go for vitrectomy. But the earlier you get to the operating room is better for their outcome, and this is a very tough case to get away with these membranes, but we could do that, and the patient ended up with silicone oil. He is attached, but still is a tough case. And I think that if you do not do so many maneuvers like that, like cautery and the retinotomies around, and if you just go in the macro area, and then when you remove the silicone oil in such a case, the chances of getting it redetached, they are much more, they get much more higher. And that's my case.
Hudson, may I ask you, do you use anti-VEGF before these cases?
Not in this case, actually, because this patient is from the foundation, and sometimes people get, so chronic, and they get to us in this situation. And sometimes we have time to use, and the system, the public system, sometimes we order, like a Avastin, like Lucentis, or even Eylea or Ozurdex, and but it takes too long. But this case, in this patient, we sent him straight to the OR, and he was operated on. We did not wait too long, and in the follow-up, since we have ordered these injections beforehand, so with time, even with silicone oil, I used to inject. So we are planning for removing the silicone oil, but not now. I usually get these patients with silicone oil for 6 months more. And then after everything is stable, this hemorrhage you saw at the end of the surgery is already resorbed. So after the eye is calm, and we did a couple of injections, and then he's ready for removal of silicone oil. Otherwise not, we wait.
Okay, nice, very nice case. Congratulations. These hard cases and hard controlled diabetics. We have seen a lot of them after they're coming back much worse after the pandemic, COVID.
Yeah, they wait too long. And the thing is that what I was saying, the macula looked pretty good. It was not for the optic nerve that had some, was pale, and other, the retinopathy and the neuropathy and other signs. The patient would probably be much better. But with silicone oil, he's seeing and counting fingers, so it was a success. But if we waited too long, we'll probably have to, not to have done that surgery. And so if we take these cases early enough, and that membrane was on for such a long time, that's why I decided to do always in these cases the double peel. And how often you do double peel in such cases, Yoshihiro, for diabetic retinopathy?
Great question. We, not all the time, to be honest. But for challenging cases, recurrent cases, I think there's a role for it. Really, I think my primary goal would be to get the hyaloid off. And if I'm not sure of that, I'll do the stain primarily to peel the hyaloid, make sure we got all of that. If we can take some ILM off the macula, that's great. I think your case was very, very illustrative of the selective retinectomy or retinotomy that you can do for these cases. And I think usually it's very challenging to figure out where you need to cut, because you don't want to cut too much in these cases. But I think you did a great choice cutting just where it was necessary. And I loved how you used PFO to kind of make sure there was no more retraction left.
Yeah, I think that's the point. You should do it twice sometimes when you are not afraid that you haven't peeled the hyalon, because sometimes if you don't do it, you maybe have some epiretinal membrane that can get your worse final visual acuity, for instance. So I think it's a double care of the patients when you do it. Congrats, Hudson. Very beautiful case.
So, back in India, how are you, Vaibhav?
All well, and enjoying today's cases. All the cases had something to learn from. And I'll also be sharing an interesting case. Can you hear me? Is my screen visible? I'm all right. I'm perfect. Sharing my case. All right. So this was a young male who had an injury with a metallic foreign body, and there were a few challenges in this particular case. I'd like to share the way I managed it. So the challenges were there was a corneal tear, there was a traumatic cataract, and there was a metallic foreign body. So there was a small corneal tear which was managed pretty well with a single suture. And then what happened is through the tear that had torn off the anterior lens capsule, we went ahead and with the IA Pro, because of the 18-year-old boy, we were able to aspirate off the lens matter carefully, just because the aim was to preserve the capsule in such a case, because we'll have to place an intraocular lens later on in the procedure or a secondary procedure, depending on how the surgery goes by. So already this B scan and the CT scan had been done for this patient, and the patient had a metallic intraocular foreign body with the impact site. That's what was presumed. So then I placed in my chandelier system, and this was the foreign body. So you can have a look at the foreign body. This was the foreign body impacted on the retina nasally, and the rest of the retina looked attached. So my experience with the chandelier is, whenever in doubt, I always place it. So because of the young male, I placed in tricot, which I normally do, and I made sure I did a proper vitrectomy, co-vitrectomy, and I induced a PVD, complete PVD, as you will be seeing right now. So tricot really helps because it confirms that you've done a PVD, especially in young cases, as shown by Dr. Athanasius as well. So I also have a routine of doing a tricot-assisted PVD induction. So here I'm sure, and you can see the movement of the foreign body immediately after the PVD. It's mobile now, and there was some amount of infective focus around the foreign body. But here comes the advantage of chandelier. So after doing a proper vitrectomy, now I can indent the sclera at the site of the foreign body and just very carefully shave off the foreign body without causing any iatrogenic breaks, because at this point it would be difficult without chandelier, sometimes with just an external support. So I was able to very carefully just mobilize the foreign body, and it fell back on the posterior pole. So now what I did was I opened up the posterior capsule, I removed the residual cortical matter, and made an opening there, because my plan was I use an intraocular magnet. So this intraocular magnet goes through a 23 gauge opening. So I did not have to extend my incision. I brought the magnet in front, I opened up the corneal incision, and then I use the forceps to carefully deliver out the foreign body and the infective focus as well. I had already extended my incision, I extended slightly further, and I placed a 3-piece intraocular lens in the sulcus. It was well centered, and this was the impact site. So the impact site, again, the chandelier helps in proper illumination and visualization. So I was able to do proper laser as well as cryo those areas that were suspicious, and do a proper examination, and finally close up the case with the intraocular lens. So this patient did pretty well, and the chandelier really helped me because I was able to do a proper vitrectomy and prevent any iatrogenic breaks, except for the retinal impact site, which I was able to manage properly. Thank you.
Very beautiful. I was amazed how you got this PVD. You sort of created this Weiss ring-like thing. You know, it was kind of like a Weiss ring, beautiful image, and tough surgery. Congratulations. Anybody wants to comment?
As our colleagues have told us in previous surgeries as well, the importance of visualization and taking each step at a time, thinking and planning your surgery beforehand really reduces your problems beforehand, because if I not place the chandelier, maybe mobilizing the foreign body without the chandelier would have been tougher choice, because you don't know how much indentation externally to give by the assistant, and that could have caused either a choroidal touch or a bleed and complicate the case. So it's always better to have a chandelier in place, and you're very, very comfortable. You can maneuver as much indentation as possible and very nicely shave off the foreign body traction from all around, and then it falls back, and you're very safe.
Dr. Sethi, great case, beautiful. I think I agree, having a chandelier is very nice for intraocular foreign body cases, especially if you don't have an assistant. I think your operating room must be a lot of fun. You had fun music, and you had like a 25 gauge infusion, but 23 gauge cannulas, Alcon cannulas, I believe, but then the chandeliers were Dork chandeliers, I believe, twin duty one. And exactly. So you had that connected to a different light source.
Yes. No, actually, I use the Dork machine, but I like the Alcon Trocars. So, and because see, this patient was a poor patient, and he cannot afford surgery, premium surgery. So we normally do a reusable cannula system. So I'm able to give him as a best vision as possible with these reusable trocars. So I kind of mix and match sometimes, because you don't have they can't afford at all. So
I see. That's very interesting. Well, your surgery was very premium.
Oh, thank you.
Can I say something? I think the goal of your surgery, Dr. Valbach, is removing the foreign body by the anterior chamber. Don't have any way to remove it if you don't remove by the anterior chamber. It's impossible to remove by scleral tunnel or something like this, because the body is irregular. I tried one time, it's impossible. You have to remove by anterior chamber anyway. Congratulations.
The last removal of intraocular foreign body that I did, I used these crocodile forceps that from Fine Hub. My brother-in-law, he makes these pieces, and it was amazing because I could get the irregular foreign body, a metal one, and I could approach the sclera, and I just opened up a little bit, and it came. Because it seems that the crocodile forceps gets and holds it stuck into the forceps. So unless it's too large, and I think it's possible to remove by the sclera. Of course, it's a lot more tough. And if you want to remove it from the anterior chamber, if it's possible to a nice incision there of the cornea, I agree with you. That could be done as well.
That's a very nice surgery and beautiful video. Just one comment, because you mentioned it, and it looks like that too, there's some inflammatory or infectious foci. And I usually get very nervous of putting in an IOL in a case that may be infectious, because the intraocular lens implant itself is a foreign body. I just thought maybe, of course, it told us that the patient did very well, and you don't want to do more surgery than needed because of the financial aspect of the patients. It potentially pose another burden. Although the second procedure can be done under local and relatively a secondary IOL insertions can be done relatively simple with a topical procedure, a topical anesthetic procedure. Opinion from the others, will you have the same, am I just being too nervous or too conservative to consider putting an IOL in when you have a concern with the infectious foci in the case?
If I may say something, Dr. said very beautiful case, as everybody said, and I think you did it perfectly. I just missed small bubble of perfluorocarbon, because when that foreign body fell down over the macula, I just get scared, because sometimes you can have a punch there and you maybe don't have such a beautiful end as you did. And yes, Dr. Lam, I would put the IOL in the second time, I would leave the anterior capsule and approach it in the second way. That's just what I said. I have to say. Thank you.
I agree, and I think the other way, the retina looked all right by examination, because as Dr. Lam said very well, if the retina was necrosed or there was more focal infection, I may not have put the IOL that time. But because there was just a small amount of focus around the foreign body, which I was able to remove, so I thought of placing it in that position and that sitting.
We did the retinal fellowship with Dr. Lam, which much honor.
Thank you. Can you hear me?
Yes.
Oh, thank you. I'm well. Actually, it's my first day on holiday for the next 2 weeks, so I'm fantastically well. It's been a nightmare, you know. Our COVID cases are increasing, and clinics are again, you know, turning to COVID clinics because of the Delta variant. But yeah, things are doing well. Family is great, and I think I'm gonna change a little bit the scenery, and I will not present a retina case, but I will present an anterior segment surgery managed by a vitreoretinal surgeon. So, Hudson, thank you so much for inviting me again in such a fantastic webinar. And so this is a 40-year-old gentleman who was hammering a nail, and unfortunately the nail you know, hit him in his eye and created a full thickness corneal laceration. Again, you know, we are the largest NHS hospital in Greece and in Athens. So we were citywide on call, and the patient came to our care. My staff on call did the primary suturing, which, as you can see, you can see my my screen, right? Yes. Can you? Yes. Yes. Fine. Yeah. So it is a full thickness triangular, actually full thickness laceration, managed with quite a few 10-0 nylon sutures, plus because the apex of the laceration, you know, the cornea was very thin, and the surgeon had problem at the end of the surgery to make the eye watertight. She had to put glue at the end of the surgery, so there is still glue. This is 1 week after the corneal suturing, and what has happened is the lens has been traumatized from the nail. There is a white cataract, and what has happened, what we saw on the slit lamp is that the iris lens diaphragm has moved forward. The anterior chamber is almost flat, most likely because the lens has been swollen. So I'm asked to manage that case and remove the lens because yes. No, I'm not playing the video. I'm discussing the case. Give me a minute. Thank you so much. So what I was telling is that the cornea consult opinion was, if the lens remains like this, then the endothelium will be damaged, and the patient will have increased intraocular pressure. So now my thinking is, and that's what I'm sharing with you, and I would like to hear from you, is that I have two options. Either go through the pars plana and do a lensectomy, or try to, you know, rescue as much as possible and preserve the capsule, so the patient has a possibility in a later stage to have a sulcus intraocular lens. So I have pre-placed my trocars because I don't know what has happened to the posterior capsule. So, I'm expecting that might have a dropped nucleus or fragments. And I start my case and from the top, and let's play the video. So I create my paracentesis. I then I will stain the anterior capsule to see if there is any break on the anterior capsule with a bubble and then with a vision blue. And then through a corneal incision, I will start my capsulorhexis, which I have initiated here, as you can see. However, the capsule is not a normal capsule, it's a very fragile, very, very unusual capsule. So with my forceps, I will try to perform as much as I can a curvy linear capsulorhexis, which the view is not great as well during surgery because the cornea is with the glue and this is a bit hazy. Then I will just put a bit of viscoelastic to deepen the anterior segment and actually visualize the flap on the capsule I have created. And then again, using my forceps, I will complete the capsulorhexis. And then initially, I will try to remove the lens by using the phaco tip. However, I'm not getting the response I want. It's not aspirating and it's too bulky in the chamber, and I don't have enough space to do that. So I changed my mind and I put an AC maintainer, and I try to do this by using my vitrector, my vitrectomy probe. And what I do is I increase my aspiration and I decrease my cutting rate, and actually it's working. So the lens, as you can see, it's quite fluffy and soft, and it is actually successfully being removed. And because I haven't done a hydrodissection, and I just want to mobilize it, I do a little bit of lens hydration here with BSS, and the lens is getting mobilized. And again, I use my vitrectomy probe, and actually I complete the case and remove the lens with the aspiration and cutting of the vitrector, which I found very safe and preserving the capsule, which, as you can see here, it's actually intact. So the posterior capsule is intact, because as you can see, stained by the vision blue, the anterior capsule is here. And after removing the lens, sorry about this, now I'm removing the soft lens matter, and finally I complete the case, deciding not to put an intraocular lens, but finishing the case there. And the patient has done well. The anterior chamber is quite deep, the pressure is okay, and the retina is flat. Thank you so much.
anterior segment surgery, you know, you were extra careful from getting this capsule and going ahead with the phaco. So, would like to comment. I would like the comments from.
Waiting. I'm looking for you.
Well done. And I think, as you mentioned, being a VR surgeon, you think outside the box. You were having trouble with the phaco tip. You switch over using the vitreous cutter with the anterior chamber maintainer. If it was done by an anterior segment surgeon, those would not be a consideration because they wouldn't have that kind of experience to like you have. I think you managed the case beautifully and able to be innovative and taking advantage your ability as a VR surgeon to manage a complicated anterior segment surgical problem. So well done and beautifully done.
Thank you.
And Dr. Francini would like to comment on.
Yes, I may. I just want to congratulate Dr. Manuel because it's a tough case because if you approach the anterior segment with softness, I don't know, I missed a word, I'm sorry. It will be a surgery with less inflammatory reaction. You can maybe use it and a second time, I didn't know if you put some lens or not, but maybe you have a place, a sustainable capsule to do something. And well, trauma cases are very tough. And if you can do the best that you can, it's always the best option. I mean, congratulations.
Thank you. Thank you so much. Thank you.
Yeah. Hello, Ruben. Thank you for inviting me for this incredible 11th edition meeting. It's really remarkable. You're going to break all the records. It's very nice. I have learned a lot. May I share my screen to show a case? Okay, so I'm going to just show you, since this was many Buckles cases and discussions, I think it's appropriate that this to share you. This case is a young myope patient that had this simple retinal detachment. We think these cases in young myopes are better treated with buccal surgery. And we were doing just a straight case, just a regular case, and we got this kind of complication in the middle of the surgery after we drain it, and I performed some drainage of subretinal fluid. And when we were up, we saw this. What's going on? What's this? Thick epithelium. No, there was this flap of this patient got LASIK, so it was kind of a surprise for us seeing this. We just removed the flap from the view and performed the rest of the case. And here is the flap of the LASIK surgery that the patient got many years ago, like 10 years before the retinal detachment. So we didn't know about that. It was kind of a surprise. And we just do the case and anyway, and it finished well. We repositioned the flap, and was just this kind of surprise that we got. This is their first PO. So the case was just really nice. And yeah, this is the video playing again. I want to move just to share with you some lessons that we learned from this case, that we should have information about previous refractive surgery in the operating room before the surgery, of course. Because there is many cases, so we mark that on the patient chart now before the surgery. If you get a flap dislocated, just remove it from the visual axis. If it's dislocated, no, even if the epithelium is opaque, do not try to remove the epithelium. And reposition the flap at the end of the procedure. Do not amputate the flap. This is not a good idea for the patient because the vision is not going to be good after you amputate the flap. So that's it. That's a little surprise that we got in an ordinary, very ordinary case. And I just brought here to share with you this case. Thank you.
On cases, and I would like Jorge Mitri to comment on your case.
Okay. Hi, André.
Hello, Jorge.
I think all of us have this problem before. I have one case that during the vitrectomy, I lose the flap. I think the problem is that the flap will have the same clarification after the surgery. He will be completely clear after the surgery or not? Because you stay a long time without with the flap out of the right position, right?
Yeah, it can
this
be
is
out
a problem.
Yeah, no, it can be out of the position up to 24 hours with no irreversible problem. It's just that we were surprised because we didn't, we're not prepared for a flap, and was kind of surprised because the patient did not told us that he had this surgery, and we just miss it in the information, and we are just there and what's going on here? It's a thick epithelium. What's going on? It's the flap that's dislocated. You just put it back. Just remove during the surgery. If you're trying to put it back during the surgery, it will dislocate it. You just will lose time. Just remove it from the visual axis, do your surgery, just forget it a little bit. And in the end of the procedure, you put it back, put a contact lens to protect a little bit more, and everything is going to be just fine. No problem. Do not try to amputate the flap, because if you do that, the patient will get a very hyperopic shift, and the cornea will have a big haze, and maybe he will need a corneal graft. Just try to leave it, do the surgery, and at the end of the procedure, reposition it, put the contact lens, and move on. It's just this simple trick. And the corneal stroma is very transparent, so you have very clear view during the procedure.
Yeah, I think you did the only way. You do the correct way. I think we have to remove it and do the surgery without the flap. Don't have any way to finish the surgery. I think one thing is use glycerin to leave it completely clear. For example, if you do a vitrectomy or something.
Yeah, in this case, we did the endolaser. Glycerin is a good idea if you have a stromal edema, but in this case, it was just epithelial edema, so the corneal stroma was very clear. And we put some visco just to wet it. But,
congratulations, André. Very good case.
Yeah, nice case.
André,
thank you.
May I ask you something?
Yes.
You just show us one way of doing it, because it never happened to me, but if it does, I know what to do now. Yeah. And that's the point of Retinawesome. You just showed us a way that I never knew that existing before. And you gave us a very good explanation. Are you a cornea specialist also?
No, I'm not a cornea specialist, but just...
You know a lot of details that I don't know anything about Bowman and stroma and everything. The only issue that I have with refractive surgery is that I've got a lot of refractive surgeons saying that the rate of, in LASIK, the rate of retinal detachment is very low. And I got a very high rate of retinal detachment. And I found out that in their statistics, the people who have retinal detachment, they don't go back to the refractive surgeon and say that I have a retinal detachment. They just come to the retinal detachment surgeon. So the guy who did the refractive surgery doesn't know that he had made a retinal detachment. That's one issue about statistics that I see.
Yes.
The second thing is that what about prophylactic examination before LASIK? Usually people see the fundus of a myopic eye and decide to do some laser or something like prophylactic laser before a LASIK if they have any lattice or anything else. But from what I know from high myopic eyes is that the tear and the vitreous is always anomalous. The attachment of vitreous in myopic eyes is not in the equator or in the periphery. It can be anything. A tear can happen next to the disc. So there is no way to my mind that I can do prophylactic before refractive surgery, because I can do a prophylactic on the 12 o'clock and it can open anywhere else, because I don't know the attachments of vitreous. And I would very much like some people like you that you have experience in showing some to see myopic eyes and what kind of vitreous attachments they have.
Yeah, you are absolutely right. Vitreous is anomalous in this eye, and I think there is a lot of vitreous cases. And I think it's one of the reasons why vitrectomy, primary vitrectomy in these myopic eyes do not perform as well as buccal surgery. We have a lot of more, the studies have shown that we have a lot of more complications. So in these young myopes, I do avoid performing primary vitrectomy. I prefer buccal surgery because vitreous is very adherent and vitreous cases is very common. So PVR, when you do not remove all the vitreous, is very often. So I think buccal is the best way to treat this patient. You are absolutely right. They show they do not have a very big follow-up of their patients, the refractive surgeries. And you are absolutely right. They don't see the patients. And many patients, they even forget they did the surgery. They do not talk anymore about that. And we are just seeing it. And if you do not look carefully to the cornea, you miss the flap. The LASIK flap is so well incorporated in the cornea that you cannot, if you do not look, you have to really look for it. And then you can get this displacement. Of course, that if you look for it, and now we are doing that. And of course, it's good to talk before with the patients, because if you lift the flap and then to explain that later on, it's going to be more difficult. Of course, that we deal with it properly and everything finished well, but like Dr. Lan said, it's never good to have surprises in the operating room.
Thank you, Hunzo. I'm very glad to be here again at 11 Retinawesome with so much friends that I made virtually, but one day I hope I see you all in person. So today I'm going to talk about surgery that may be or not may be an option for you, but I'm going to talk about the macular buccal. that was wrong here. I'm sorry. So this is a female, 44 years old, very high myopia, complaining about visual loss 10 days ago. And her visual acuity was at the right eye 10/400 with minus 29 dioptry. And at the left eye, hand movements with minus 25 dioptic. She had a cataract, the 2+ in both eyes, and IOP was okay. So this is the fundus that I saw, that a very big staphyloma at the posterior pole at the right eye and at the left eye also. Here we can see that she had a macular hole and a macular detachment, but the detachment was also all over the staphyloma, the posterior pole. At that time, we tried to do an OCT, but sorry, that this is all in my front. That it was not possible, even with the contact lens, because the fundus was so the actual diameter was so big that even with contact lens, we could not reach properly to perform the OCT, but we could see here that we had this macular hole. So we did an ultrasound, and the ultrasound, the anterior, the diameter was 32.99 millimeters. And then we were planning and thinking about how to approach this eye. So we know that the mechanical traction of the posterior staphyloma, the long axial length, and the IPR, poor function, and the choroidal degeneration are goals for failure in macular holes, myopic eyes. So we decide to perform the macular buckle with phaco without IOL, and posterior vitrectomy, and IOL peeling, and a gas. So that we don't have macular buckle in Brazil, so it was challenging to discover how to perform it. But as my husband is a neurosurgeon, and I showed him the surgery of Barbara Parolini from Italy, Brescia, and he told me that this is a microplaque for osteosynthesis that they use at neurosurgery to fixate the bone, and sometimes buccal surgeons use for plaques to fix the mandibular tooth. So we took this microplaque and a spheral band, 506G, and a sleeve. This is the same sleeve that Dr. Natarajan used to fixate the 42 band when he did the buckling surgery. So at the beginning, we have to do this paracentesis because the pressure can go high. And then what we did, we used the whole microspheral plaque, we put them into the sleeve, and we put the band at the end of the buckle. Here we are trying to see, because this was the first time that we did it, we were trying to see if the band was under the macula. So we did this slight movement, and with the Sanjali already positioned to see if it was under the macula. Then we took some of the rings, those rings, we took some of them to make it smaller. Then we positioned the microsphere, the macular buckle, at the right position. Then we sutured it with two points, and we performed the ultrasound during the surgery to see if the macular buckle was under the macula in the right position. So it was in the right position. So then we performed the phaco emulsification without the IOL because the eye was so big. Then we did the vitrectomy. Then we put the brilliant blue to peel the IOL, and it was an IOL that was a little bit friable, but we could take it off. And we did a double staining to see if the IOL was was well peeled, because I think when you do the macula hole, you have to have the attention to remove a very good area of the IOL, because this is one of the causes of macula hole failure. If you don't remove a very big area, big size of the IOL. And then we did retinotomy, and we performed the fluid exchange, not from the hole, but here. Then we did the laser, and this is the end of the surgery. We left with gas. This is the first post-operatory impression, and this is 1 week after the surgery. Here you can see the first ultrasound with 32.99 millimeters, and then here with more or less 30 millimeters, maybe 31, but it was a considerable reduction. We could use the instruments very well. We do not have any difficulty to approach because of the length of the eye. And here we have the adequate movement. You see that you don't see the microsphere, the macular buccal, as suture over there. She can move the eye. One of the complications is strabismus, but until now she's very well. This is the 7-day post-operatory image. The retina is attached. We couldn't do the OCT yet, but I can bring it in the next time. I would like to thank all our team, Dr. José Afonso Ribeiro, who did the surgery with me, Dr. Rodrigo Jorge, who is the head of our service, and all those fellows that help us a lot. Thank you so much. And I would like to hear your considerations. If you do macular buccal, if you don't do it, if you think that it's useful, or any consideration that you have. Thank you.
Team that you involve in the surgery, and of course it takes such a more time, of course, for you to get an ultrasound on the spot to the surgery, and the materials. You said that you use the same material as Natarajan, but this was so amazing, the results, and congratulations for that. That's my comment. You know, I don't have words to say such nice procedure.
Can I have a word, please?
Okay.
Hello, I'm Marcelo. Francine, nice case. I love your procedure. I was going to ask about choroidals. No, if there is a big risk of having choroidals in this procedure with the macular buccal. So, what's your experience with that?
Well, actually, I don't have a lot of experience because this was my first case, and we were following her very closely just to see if she has any problem. But until now, everything is okay. I think one of the concern is to really to do the paracentesis in the beginning, not to leave the pressure go high, because sometimes when you touch under the globe, you may be a choroidal detachment because you increase the pressure, and then when you do the phaco, for instance, you can have some choroidal hemorrhage. But we didn't have any problem with this. I tried to put the macular buccal very, it doesn't look very careful, but it was carefully to put it under. And Barbara Parolini, she described it. She put chandelier into the sponge, and then she introduced the chandelier with the macular buccal. But as we just have one chandelier at that time, and we had another surgery, I was afraid of taking off the ponteira, the capsule that involves, so I could destroy it, and so I would need it. I didn't have another one. But I think if you just put the chandelier through the eye, you can see with the slow movement that it's at the right position if you don't have an ultrasound to perform during the surgery. And another point that I think I would do it in another way was to put the chandelier at 12 o'clock or near the 12 o'clock, actually, because I put it at the position that you use to do the vitrectomy. But when you have to move the eye, the chandelier don't stay very, very stable, actually, because you have to put the eye down. So I had to take it off. I used 25 gauge. I had to take it off. And then when I was when the buckle was positioned, then I introduced it again. But I don't have much case to say anything else. But thank you for your question.
No, thank you.
So, yeah, a wonderful case, Dr. Francine, and luckily we have macular buckles made in India itself, so we use that. And Barbara, I usually, these sort of patients, I sent my photos and OCT to her, and she advises. I have 2 cases to come in the coming weeks, apart from the past one. So one is already vitrectomized and has a pocket of fluid in the posterior staphylogram, as you showed. And in that, she advised, let us put a macular buckle. Once the retina settles, she wants me to do the ILM peeling as a vitrectomy 2 months post buckle. So that, as Dr. Marcelo was asking about choroidals, I think maybe we can avoid, I'm not sure. But whatever I've done, fortunately, I've not seen the choroidals. But I think in a high myope, you have to be careful, particularly avoid hypertonia between the procedure. So I think, and as you said, the placement, we use the illuminator, which is there in the tip, so you can see whether you're keeping at the proper place. And then in case you are injecting gas, you can position the patient prone position with the macular buckle. But I think it works. So I think these sort of eyes, I think earlier I had used Denziron and silicone oil, but I think unless the posterior cephaloma is supported with a buckle, I think the recurrence is a problem with the macular hole detachment with the posterior cephaloma. I think you've done an innovative idea of talking to your neurosurgeon, your husband, and I think you've done it really great.
I didn't know how to find that. I really didn't know what it was. So it was a lot of help. Thank you, Professor Natalia.
Yes.
Francine, congratulations, very good case. But don't you think that the size of the 506 silicone sponge is a little small to the size of the staphylome? When I see one part of the staphylome, it is very good solution, but beside it, I see that one part is not covered by the silicone sponge. Don't you think about using double sponge or something like this?
Thank you, Dr. George Dimitri. I admire you so a lot, but actually, I don't know. I don't think that we could use both sponge actually, because nothing that you do, instead you ask for somebody to do a round sponge for you. For instance, you're going to flat all the posterior pole, because it's not small actually. You see that you involve the optic nerve also. So when they proposed to do this macular buckle, was to bring the retina, to bring the globe and to smallest, to make it smaller, and to flat the macula, so you can keep the hole attached, and to avoid the forces that makes the globes goes down, and the choroidal attraction and all those forces that are involved in the failure of the macular hole surgery in high myopic eyes. And actually, Barbara Parolini, she used a 507 sponge, but we didn't have it. So I have this 506, but I think it worked well. The problem for us was to know, because she didn't explain in her video, the video that I saw, how long should be the microsphere. So you have to do like an L, And what we did, as the eye was longer than the papers that were published before, we set, we left 4 rings to the scleral buccal, to the macular buccal, and we left 5 to the length where you can take it and to put it under the macula. But I think it's better to leave 3 to this part of the L and 4 as length, because it will going to be stable, and maybe I don't know, for a smaller size you don't touch the optic nerve. I didn't feel any resistance when I put it, because this is a concern. And as I used to put some plaques for radiotherapy, so the brachytherapy, I can feel. I usually feel the resistance of the optic nerve, but it's something to concern also. So I think 3 to this part of the L and 4, it's okay, because otherwise you can maybe have it a little protrude at the anterior, not anterior chamber, the anterior segment of the eye, maybe.
Congratulations, very good.
Thank
For
you.
the first surgery, I think you have a lot to learn and to teach us how to do it.
A lot of fun, for sure. Thank you.
Good. Thank you, Hudson. One moment. Yes. Can you see me? Yeah, now it's okay.
Yeah, I see you, but
We see you, but the screen.
Not the screen. One moment. Now it's okay. Okay. Francine showed a very interesting case, and I will do the same. I try to do the same. Let me talk about the macular roll. I think when we start to remove the LMI, we have 2 big problems, I think. One is that vitrectomy with the silicone oil, with the flap, it's close more easily the roll when you use the inverted flap. But what we see is that the visual acuity, it's a little better, what the work said, that when you use the flap inverted, you have a little or almost the same vision. But we have to make some consideration. Wow. One is, when you remove the ILM, you are removing the basal membrane of the glial cell. And glial cell has a lot of function. It's not the arcabosus of the retina. So you leave the retina much thin, and you make very common scotoma, paracentral scotomas. So the vision is not so well. We have, all of us has this problem. You do a big and good surgery, and the patient is not happy. Every time they said, no, my vision is not good. Since he is seeing 20/30, he said, no, I see some distortion, I see something, some shadow in my vision. I'm not happy. So this is the other function of the Miller cells that you can see. It's a lot of things that they do. So when you remove, you are destroying a lot of function of this, okay? They control the extracellular fluid. They regenerate the rods and bastonates, and many other functions. So my idea is make this kind of surgery. We make a big area, we see in the right side, a big area of removing the ILM, but don't remove it in the center. Just in fovea, you leave the limitant membrane. So with this, what will happen? You will relax the retina, but you do not case of scotoma in the central space. So this is the surgery. I think this not. This is how I do. I remove a lot of limitant, but don't remove in the center. Can you see the video? Are you seeing the video? Right. Okay. This is the fovea. This area is the fovea. So I can just remove beside a big area and leave the limitant over the fovea, just the fovea, but cover with the limitant, okay? This is the idea. So I did in 2 cases, then I have here the results and I will show you. I don't have a better visual acuity because I have less than 15 days each case. But I will show you. This is the pre-op and this is the post-op. You can see it. Wow. One moment, I lose my, I don't know what happened. Here. Now it's okay. I don't have any case with edema. The idea, if you can see here in the third photograph, you see that the retina in the periphery is very thin, but in the middle it's very thicker. So the idea is leave the fovea without touch. So you relax the rest of the retina to close the roll, but don't touch in the fovea. Because I think any touch you do, you make a lesion in the photoreceptors. So you see here that you see some irregularity, but this is 10 days after the surgery. You can it's closely and it's stick still. And this is another case. I did. This is the last one. It's a big roll, you see. And after the surgery, you can see that the fovea is still thicker. So the periphery is fine. So this is the idea of make the macular roll has a good vision after this beautiful surgery that we close but don't see anything. It's finished.
And I would leave it up to Dr. Marcelo Murillo, who's going to present the next case to comment on your case. Really cool images, Jorge Mitri. And I like the idea. It's pretty easy to not to go until you remove the ILM totally, I think it's not a problem. I don't know what do you think, Marcelo, and whoever else. Should we remove it all, or we should remove and keep at the foveal area?
Well, actually, it depends the case. Sometimes the inflammatory reaction is different. So just observe. No, it depends the case. It's not always the same procedure to perform in these macular surgeries. That's my opinion, Hudson.
Well, how will you do that approach? You know, my preference is to remove it all, and my preference is to remove and leave a stalk somehow, sometimes to do it inverted, so I keep the ILM there without escaping off the macular area. But this idea from Dr. Jorge Mitri is very interesting. What your thoughts are on that?
No, I agree with Dr. Mitri that it is not necessary to always peel the IOM. In fact, it is harder to preserve the IOM than to peel it. And so I think technically it's more demanding to leave the IOM at the fovea edges. And I think he has shown wonderfully that without removing the IOM, you still can allow the macular hole to close. I'm pretty sure the creator make IOM for a purpose. So I don't think we should just so carelessly to remove it without considerations. And there are publications showing that the removal IOM has been shown by Dr. Mitri that can cause difficulty in vision, such as paracentral scotoma. I think this is just reassure us that the surgery can be done without the IOM completely removed. So beautifully done. And I think that I'm actually doing the same thing. I'm trying to preserve the IOM as much as possible and using the inverted flap technique whenever it's possible.
Yes, the idea is to leave the IOL over the macula, the fovea, just to close it, because we know when we use the IOL over the roll, it's closed easily. For this reason, I don't remove and put over it, over the fovea, and close all the two cases.
Just to say something, and I was just add actually, because when we didn't know about the IOL, that we could peel IOL in the beginning, we used to I don't know, comb the retina surface to close the hole in the beginning,
yeah.
10, 15, yes. 20 years ago, and the macula usually close, and sometimes the patient would have a small scotoma in the center of the vision, and he could use the peripheral retina, and with a very good vision. I have some cases that I did in the beginning with this technique, and if I'm not wrong, near less than 10 years ago, somebody described, I didn't remember, I'm sorry, this technique as relaxing IOL to close macular hole. The point here that Dr. Mitri is saying, that what I understood, is that you don't have to remove the IOL over the fovea. So you couldn't damage the photoreceptor there. And sometimes we have that malpositioning when they came down again. And I think the technique is almost the same. You are relaxing the border of the hole so it can reattach, and then you are using the flap, but not a flap that you put inside the hole, which you could damage more. because it's very beautiful surgery when you put the flap inside the hole. I personally don't like to put the flap inside the hole because I'm afraid that you can damage more the photoreceptors. So if I do it over, as he said. And I think the principle is all this and the point is, when, as I said in my case, when you remove a very big area of IOL, you can close even the holes more, even the holes in the bigger holes. I don't know if
yeah, really. You have
things the same, because you don't stretch it, so you have a large area to put it together.
Yeah, sometimes you cannot remove completely in one way. You have to cut it in 3 pieces, but you have a lot of limitant to put over the roll. You know, this problem you don't have. You have a big flaps of, so you can close the roll just putting it over the limitant over the roll. This is an idea. I'm not sure if it will works very well, but it's idea to don't touch the roll and close it. Okay.
Very nice. Let's see the result at the 12 Retinawesome, Dr. Jorge.
Marcelo Murilo Sasamoto from Bolivia. We are almost close, you know, the country is side by side, and we feel you as if you were here, Marcelo. And muchas gracias por estar acá, and congratulations, and expecting to watch our case.
Thank you, Hudson. It's always a pleasure to share with such a very unique group of surgeons, of retina surgeons. Well, my case, these cases that I present are cases where less is more. Speaking of late ROP surgeries complications. So we will start with the first case. Okay. So the first case is a rough patient with late complications, a male, 18 years old. The first surgery was a scleral buckle, a sponge, with posterior hyaloid removal, endolaser, and silicone oil. Later on, the second surgery, 15 days, was a posterior hyaloid removal again, because of this is one of the big complications that we usually have in these ROP surgeries. So I will start with the first one. So you can see I'm putting first the scleral buckle, the sponge. You can see all the retinal detachment, all the avascular zone. This is an 18 years old male. So the difficult part is to remove all the hyaloid that is in the eye. Something important of this case is that the first week we believe that the patient was doing well, doing fine, and 15 days later was really a mess. I mean, the posterior hyaloid start to traction all the retina. We did a second surgery to reattach, and it was really a tough case. So as you can see the pictures, this is the post-op. Everything was doing well, and then start the traction 10 days post-op, and you can see a big hole near the macula and all the tractional and tissue that was there. So we did the second surgery to remain the retina attached. It was really a tough procedure. Then the same eye got a retinal detachment of the same patient, and we performed 3 surgeries. Let me. I think here's the video. Yes, we performed 3 surgeries. The first surgery was a scleral buckle, silicone band, and vitrectomy, posterior hyaloid removal, and the laser and silicone oil. Then, almost similar, 15 days post the first surgery was a posterior hyaloid removal again. And the third was the change of the scleral buckle from silicone to a sponge. Because of the traction, we did the third surgery, and I think was the game changer in this eye. So as you can see, we're performing the removal. Currently, these procedures are actually, I divided in 2. When it's a raw plate complication, I prefer to perform first a scleral buckle, wait 10 days or 15 days, and using methotrexate to stabilize the eye, and then perform the second surgery if needed. So doing less in these cases, I think is more for the patient. As you can see, all the hyaloid is so thick that it's really difficult to remove it all. So these type of cases are really difficult ones. So when we use methotrexate, I use first 4 days before surgery, then during the surgery, then 7 days later afterwards, then 1 month until completing 6 months. It's like the same principle as the retinal detachment with PBR. So I will show you in the next Retinawesome the cases with 2 types of the same patients of this raw plate complication, but divided in 2 different surgeries. You know, as I mentioned, I think this is more important, and it's there's more efficiency when we use 2 types of surgery instead of 1 big surgery that produces a lot of inflammation in these patients. So that's my case, and we can discuss about these cases. Thank you.
I was just wondering, you like using methotrexate. I think we should use more. And could you tell us how to use it in the dosing and details?
Yes, at the beginning we use 1,200 micrograms of methotrexate. Then when we're putting the monthly dose, we use 400, similar to some papers using methotrexate for PBR. So that's the dose. At the beginning is 1,200, and then we reduced to use 400 every month. The first 3 months, I use it every week or every 15 days, and then after the 3 months post-op, I use it every month.
On Marcelo's case, we are moving forward to the last case from Naga's work, but yeah, Francine, could you?
No, yes, Dr. Marcelo, very challenging case because it's so hard to deal with retinopathy of prematurity. So I would like to ask you if you perform the surgery in 2 steps, and between this step, when you do the first surgery to perform the macular buckling, and you use the regular buckle always, or do you use the sponge as you change it for a sponge? It was a radial sponge under the hole or the rupture, or it was a circle sponge?
It was a 360 sponge. But when there's a lot of traction and there's a failed procedure, first procedure, I prefer to use the radial sponge. but usually I use the silicone square buckle.
Okay. And do you perform triamcinolone at the end of the surgery, the first one, or methotrexate?
Both, because triamcinolone is very good for remove the posterior hyaloid. You can recognize better, but at the end I put some triamcinolone. Yes.
Okay, thank you.
Thank you.
Was the president, the former president from Brazilian Vitreoretinal Society, and we work together in Brazil. And thank you, Marcelo, for being here. And I'm going to call for the Nageswar Rao to present the last case, but always last but not least, because he's very good. Thank you very much, Nageswar. I can't hear you yet, Nageswar. Yeah, are you? Yeah, I see your screen.
Thank you. Thank you, dear Hudson. So, can you see my presentation?
Yes, we can see.
Is it visible? No? Okay.
Yes.
Okay. Today I will be speaking on a rare entity, which very recent past actually I came across with this case. He is a 60-year-old male by profession. He is executive. He is a director of some company. And during this pandemic, just 2 to 3 months back, he made a teleconsultation regarding his left eye because he had red eye, and that was subsided because it was intense pandemic was going on. There was lockdown was there. So he had to, he could not visit any ophthalmologist nearby, and he called and made some teleconsultation regarding his red eye. Then that subsided with topical medication. But a month after his red eye, what he noticed, he complained of profound loss of vision. He actually noticed complete loss of vision in his left eye. And then he came to me. That time, the entire segment was very quiet, and the lens was clear, and there was dense vitreous hemorrhage and inflammatory debris. It was filled with inflammatory. I could not see the retina. It was completely, the vitreous was filled with hemorrhage and inflammatory debris, and there was no fundus view. So the ultrasound showed like this. There is the vitreous is completely filled with this kind of heterogeneous echoes, membranes also few. And I thought of its hemorrhage and some, because it was showing like actually funduscopy, and there is a detachment which is here, that thick, or I thought of it maybe because it was showing like inflammatory, maybe thick PVD or a detachment I thought of. Then we posted for surgery. And he was not a known diabetic, but preoperative assessment for blood sugar came normal, and the viral markers for HIV, HCV, and hepatitis B virus, everything came negative. Then we posted for surgery. Then this is the surgery. See, the vitreous is completely filled with inflammatory debris, very dense vitreous haze. When I cleared gently, I had to, because he's a high myope, his retina was very thin. Then very gently induce the PVD to lift it off. And this is the thick vitreous PVD which is there. And here you can find tears in the thin retina. The retina is very mobile. There was detachment here. And gently, when the media got clear more and more, I could find this kind of lesions in the periphery, almost in the equatorial region. The retina was necrotic, patchy necrotic areas throughout the equatorial zone and the periphery. Although the center was clear and there was peripheral necrotic retina was there. Then at that point, I thought it probably maybe because of some infective etiology, the retina got necrosed. Then I thought on the table, because the retina, peripheral retina, and with some pigmentary changes sideways. So I thought of this is a case of, I'm dealing with a case of acute retinal necrosis. So the PF cell injected posteriorly to flatten the retina. This is, I decided it is clinically acute retinal necrosis syndrome, ARN, and eventually the retina got settled with fluid exchange and laser and silicone oil injection. And we sent the vitreous sample for PCR analysis. It came, what I was suspecting, it came varicella zoster, which is the commonest organism to see. And although the herpetic virus family, so many viri they can cause this syndrome, but prominently varicella zoster, which is the causative agent for this ARN syndrome. And subsequently, oral acyclovir, and I started oral acyclovir steroids. Still, he is continuing with oral acyclovir because I wanted to give for long term, at least 3 months, and topical application of antibiotic, steroid, and cycloplegic agents. Then the retina, we took after 2 weeks. It was still the bit of edematous. Gradually, it has cleared. The retina was more and more clear after a month, 4 weeks of surgery, and this is final visual acuity. That point of time, I saw him maybe a month before. 624, he's very much obliged to me because completely the loss of vision, he was PL after that surgery. Now the retina is doing well with the pigmentary changes. The retina is flat. This is what my case, acute retinal necrosis syndrome. Thank you very much.
The retinal periphery with laser and off, and after some time, the retina is beautifully attached. Congratulations. I liked very much your case. And would anybody like to comment and close the session? I would like very much your comment, Dr. Lam, from Nagaswar case. And would you do anything different?
No, I think it was wonderfully done. The outcome, as we all seen, is excellent. Looks like the acute phase of the ARN has settled because you see mostly pigmentary changes and those probably sequelae of the necrosis with the retinal breaks. And what I find interesting is that the exact etiology, like why do people develop ARN, and then and the subsequent management, because some of those patients actually require a long period of antiviral medication, systemic, in order to prevent recurrence. I have one patient, a young woman, who actually was on acyclovir, and at that time it was acyclovir, and for almost a year, and then when we stopped, she recurred. So some of those patients can actually needs ongoing antiviral treatment to prevent it. Is anything in the history for these patients that may have like point to the reason why he will develop ARN? Because sometimes we can find history of that recent exposure to chickenpox or being in around children with chickenpox. Does this patient have any history that can help you?
Yes, here in fact in India, chickenpox is a very usual occurrence. Actually, almost everyone they get during their childhood. So he had actually chickenpox during his childhood. So the virus remains indolent in the nerve tissue. So that aggravates at certain period, maybe.
Right. So very astute of you to take samples, because that really helps to confirm the etiology, makes the subsequent management much easier and more directed.
Thank you.
Everybody here that stayed, but until now, and I'm sure that everybody learned a lot, including me. And I'll leave it up to you, André Jucá, for closing this edition, the Retinawesome 11, and we invite you for the next Retinawesome, which will be together with Ophthalmo Cordoba next October 29. Are you around, André Jucá? Or else, if you are not there yet, so please, Dr. Lam, you are the best for this. Thank you.
Well, thank you. Well, it's always an honor to participate. I can speak on behalf of all the participants here. And I think we see a wide range of cases, from the pediatric cases that Yoshihiro shared with us, complicated and yet very skillfully managed, and to the complicated infectious cases of ARN. I think, as you said, we all learn very well from each other, and I particularly love the exchanges between the experts. And I think that in addition to see the beautiful surgery, the discussion gives us invaluable pointers to take home and do better for our own patients. And I think, Hassan, you do an excellent service to all of us in this VR professions, and ultimately it's always our patients who benefit. So it'll be exciting to look forward to the next versions of Retinawesome. And thanks for all the presenter for sharing that beautiful video and the pearls and their expertise.
Thank you, Dr. Lam. And also thank you for having your residents and fellows participate. This is amazing, you know. We love to interact, and I hope this continues. So I will leave it the word. Thanks, Marcelo. Thanks, Francine. Thanks, everybody. Nagaswara, too.
I make sure the fellows stay up. It's midnight here. So I told the fellows, like, they can go to sleep until this is done.
1 p.m. here in Brazil. We have your 11 hours before you. That's great, and thank you for staying, awake.
No problem. No problem. Tomorrow is Sunday, so we can sleep in.
Okay.
Thank you. Thank you.
Thank you all for this morning. Be
Bye-bye.
kids and stay safe. Bye-bye. See you the next time.
Recording stopped.